Hello, hello everybody. Good day, Merry Christmas and a Happy New Year. I have the pleasure to join this meeting as a moderator in an interesting section dealing with pregnancy and diabetes. It is an important topic, knowing that 2 of 4 women with diabetes are in reproductive age. 1 of 7 births are affected with GDM. And there is a high risk mortality and morbidity in this pregnancy during diabetes. So we have 3 important lectures. I will let my colleague Mariam Al-Hajri to begin with. Dr. Mariam.
Good evening, good afternoon for everybody. It is my pleasure to chair the session Diabetes and Pregnancy with my colleague, Dr. Hana Al-Ghanem. And I would like to thank the organizing committee at IDF MENA Congress 2021. This session is under the title of Diabetes and Pregnancy, and the first speaker will be presented by Professor Mohan. Dr. Mohan is the chairman and chief of diabetology at Dr. Mohan's Diabetes Specialist Center.
Dr. Mohan also is a president and a director of a Madras Diabetes Research Foundation. He published more than 1,030 papers between articles and review articles. He has been awarded by the IDA and the government of India. He will tell his lectures will be about gestational diabetes mellitus. Dr. Mohan, the floor is for you.
First of all, thank you to the chairperson, Dr. Hannah and Dr. Mariam Al-Hajri for the kind introduction. I would like to thank my very good friend and colleague, Dr. Professor Shabin Nas Masood, and also my very good friend, Dr. Jamal Balkadir, for inviting me to this meeting. I know it has been postponed once, but now we are on Christmas Eve. And therefore, let me also wish all of you a Merry Christmas and a very happy, healthy, and successful New Year. So the topic allotted to me is on early GDM. So what is this early GDM and its impact on perinatal outcomes, I have said. And this, of course, comes to you from India, from Chennai in South India. I have no conflict of interest to declare. Some of the studies which I'm going to present are from the International Diabetes Federation funded project called as the WINGS project. And we also have other projects funded by the UK government and so on, which I will show you in due course. So let me plunge straight into the subject in the interest of time. What is early glucose? What is early gestational diabetes mellitus? Normally, the recommendation is that we screen in the second trimester of pregnancy between 20 to 24 weeks or 24 to 28 weeks actually. That is when GDM is traditionally diagnosed and that is when we screen for it. If you diagnose it earlier than that, say less than 24 weeks, 16 weeks, 14 weeks and so on, we call that as early GDM, and we have coined this term called as eGDM so that we distinguish it from conventional GDM, which we call it as cGDM. For the rest of my talk, I'll be using this eGDM to show early. That means in the first trimester itself, it is diagnosed. Now, why should you diagnose it early? Because type 2 diabetes is increasing. It is occurring at a young age. And so if you don't screen in the first trimester, you will miss pre-existing diabetes also. But that is not early GDM. There, the HbA1c will be high and the sugars be very high, and you know it's pre-existing diabetes, it's been missed. We are talking about early GDM, which is diagnosed during GDM. Now, in 2010, based on the HAPO study, the International Association of Diabetes Pregnancy Study Group, or the IADPSG, proposed a diagnostic criteria for GDM. In fact, it is this IADPSG criteria which is now accepted by WHO, ADA, IDF, and all the other organizations have accepted it. And we in India also predominantly use the IADPSG criteria. I personally think that this is the best criteria to be used, because it checks the fasting, then you give glucose, and then 1 hour and 2 hours, and we'll come back to that. But they've also proposed a criteria for diagnosing GDM in the first trimester of pregnancy. So before 12 weeks or in the first trimester of pregnancy, if the fasting glucose is between 92 to 126, we know that's above 126 or the HbA1c is above 6.5, it's overt diabetes. But what if it is between 92 and 126? This 92 came because during the second trimester also, fasting more than 92 is taken as one of the criteria by the IADPSG criteria. But IADPSG doesn't ask us to do GTT in the first trimester. What they're saying is check fasting glucose. If it's more than 126, it's overt diabetes, treat it. But if it's between 92 to 126, it is GDM or early GDM. And if it's below 92, it is normal. And then you do again a GTT at 24 to 28 weeks. That's what IADPSG says. Now, what is the importance of identifying this early GDM? Because this early screening identifies women with hyperglycemia who do not have overt diabetes. However, as I will show you some preliminary results from our own study, unpublished now, but under publication, this early GDM, if you compare it with the conventional GDM, it is more severe. Although it is not diabetes, still it is more severe and it is more insulin resistant. These women also have higher blood pressure, triglycerides, perinatal mortality, neonatal hypoglycemia. There is more need for insulin. But the literature has confusing results because proper studies on eGDM have not been done. We have done an extensive study which we have just published, and I'll show you that. One of my PhD students, Wesley Hanna, along with Balaji Bavadarani and others, and of course our collaborators, Dr. Professor Saravanan from UK, my own collaborators, Dr. Umaram, who frequently speaks in the sessions which Dr. Shabin organizes. And then we have some collaborators also from Australia. These are from the Deakin University. So all of us together wrote this, and this is part of Hannah's PhD thesis. So she just published this article in September 2021 in the Acta Diabetologica. It's a very big review. It's a systematic review of early GDM. So what she has shown, she has reviewed all the articles published on early GDM. There were 58 studies where the GDM was diagnosed before 24 weeks. And in 41 studies, the prevalence was reported. Look at the prevalence, ranging from 0.7 to 36.8. This wide range is due to differences in diagnostic criteria. Some have used some criteria, some have used other criteria. There are no standardized studies. Birth outcomes are available in 23 studies, and they showed that those who have early GDM have macrosomia, cesarean delivery, induction of labor, hypertension, shoulder dystocia, just like the conventional GDM. So this is not something which we can ignore. We don't know whether we can call it as GDM or some other name will come. We are calling it as eGDM. This is a term which we have given for the first time in literature, and the name may change later on, as I'll show you after the Toboggan study. But right now, the eGDM results are confusing because they're all retrospective studies. They're not prospective studies. Another meta-analysis was done by Emmanuel et al. In 2017, where 13 cohort studies were done. And they showed that in this early GDM women, compared to the late onset or the conventional GDM, perinatal mortality was higher, neonatal hypoglycemia was higher, and insulin use was also higher. So if anything, this early GDM is more severe than the conventional GDM. Maybe that is why they got it in the first trimester. Now, we are involved in a study which has just been completed. It's called STRIDE. It's an Indo-UK study, and the name STRIDE comes from Ethnic Specific Risk Stratification Early Pregnancy for identifying mothers at risk of GDM. So it's abbreviated as Stratification of Risk of Diabetes in Early Pregnancy, or STRIDE study. Now, the aim of the STRIDE study, we did not set out to diagnose early GDM. We thought if we study them before they got GDM, we'll be able to identify using some risk scores who will get GDM. But in the process, when we started screening the women in the first trimester, we picked up a lot of GDM, which we called as early GDM. Now, this is a very large study, 3,000 women, pregnant women, recruited before 16 weeks of gestation. I think this will be the largest study in the world when it is published. Age between 18 to 50 years. And here are our collaborators, Professor Saravanan, we call him as Sara, from the UK, from Warwick, Dr. Umaram, my collaborator from India, and we have study centers in Hyderabad, in Chennai, and in Puducherry. Number of sites is a very large study. 3,000 women have already been recruited, of which 2,700 we are able to recruit, and we are able to do the fasting plasma glucose. And you can see that 78% were normal. They had below 92. And then we had this high fasting glucose or early GDM in 566 women. This is one of the largest series of early GDM. So 20%, almost 21% of women, when we screen them in the first trimester before 16 weeks, we are able to pick up abnormalities. Now we have excluded those who had overt diabetes. And despite that, we have such a large percentage of eGDM. And of course, the conventional GDM also, we had 359. Okay. Now, when we further looked at, when we further did the OGTT, many were confirmed to have GDM and others did not. Because you know what happens when you diagnose them in the first trimester, they go on a strict diet and they lose weight, and therefore they can become normal also by the second trimester. Now, this slide, actually compares the women who had normal glucose tolerance and the early GDM and the conventional GDM, and fairly large numbers, as you can see. Now, if you look at the age, they were about the same. But look at the weight was higher in the early GDM, BMI was higher, waist circumference was higher, the fasting glucose was higher, HbA1c was higher, venous glucose was higher. Everything is higher in the early GDM women compared to the conventional GDM women. Of course, much higher than the normals. Now, I'm not giving you further details of the STRIDE study because we are now publishing the outcomes. We are publishing many aspects of the early GDM. Only the review article has been published. Now, series of articles should come out next year. And therefore, at the next IDF MENA region conference, I may be able to present more data from our STRIDE study. In the interest of time, let me now go on to a very important study called as a toboggan study. This is almost like the IAD PhD study. It's done by the same group, David Simmons and others. What is toboggan? Toboggan stands for Treatment of Booking Gestational Diabetes Mellitus. It's the first multi-center RCT of the diagnosis and treatment of hyperglycemia in women before 20 weeks gestation. That means it's early GDM. And this toboggan will finally solve what is this early GDM and what treatment should be done. And if you treat or you don't treat, what will happen? This is a group of investigators led by David Simmons from Australia, from Western Sydney. And we are one of the collaborating centers, one of the few centers outside Australia, actually. So there are 16 study sites, mostly in Australia, but also from Austria, Sweden, and from Chennai, our center has joined. So we take women, singleton women without pre-existing diabetes. BMI should be more than 30. Past history of GDM should be there. And macrosomia, first degree family history of diabetes. And we study the ethnicity also. And this is the criteria used to diagnose the early GDM. If the fasting is more than 126 or 2 hours more than 200, it's overt diabetes. And if it is between 108 to 125, we call it as high fasting. Between 96 to 108, we call it as high risk group. And 92 to 95, very mild, we call it as a low risk group. We are trying to see whether this low risk group has a lower risk than the high risk group and the other groups. And the 2 hour values, 1 hour and 2 hour values used are also shown here. So we divide them into 4 groups. The first group is a booking GDM therapy intervention arm. In one arm, we are not treating at all because there is no guidelines to treat now. And therefore, we are justified ethically not to treat. So we have 400 in each arm. And then the no GDM treatment group, decoys, where we just put them into the group to see how they would be treated like normal GDM would be treated. And then, of course, non-active also we have. So these are people without GDM. So this is a very large study, as you can see, one of the largest ever done. And this will conclusively tell about the early GDM. We expect to get the early GDM prevalence done in a proper way. The natural history of early GDM will be shown. Treatment effects on early GDM will come out. Cost effectiveness screening, diagnosed treatment early GDM will be also shown. The screening and the randomization for the toboggan study has just been completed. I think by January first week it will be over. From then on, all the outcomes, and I think by the end of next year we should have the study completed and the results will be presented. So I'm going to stop here, and these are my take-home messages. Early pregnancy screening for GDM is mandatory, as it helps in identifying pre-existing diabetes and also early onset GDM. More work is needed on eGDM, but it must be diagnosed and treated, as otherwise the outcomes can be poor, as already the retrospective studies have shown. But the final answer will come from the toboggan study, which can throw much more light on eGDM. And with that, I will stop sharing and thank the organizers, thank Dr. Shabeen and Dr. Jamal Belkadir and the two chairpersons and the organizers for giving me this opportunity. And I look forward to listening to the other two speakers, and we'll have the questions later. Thank you very much.
Thank you, Professor Mohan, for excellent topics. Now, the second speaker, Professor Nadima Shegem, she will give us the topic about inertia and screening and diagnosis, hyperglycemia and pregnancy. Dr. Nadima, a specialist in both endocrinology, diabetes, and internal medicine, was a full-time consultant at Jordan University Hospital's National Center for Diabetes, Endocrinology, and Genetics for 7 years before she left to found her own private clinic. In the time since, Dr. Shegem has also become president of the Jordanian Society for the Care of Diabetes and vice president of the Jordanian Society for Endocrinology, Diabetes, and Metabolism, and the co-author of several publications. In her spare time, she volunteers at several humanitarian and cultural outlets. Dr. Nadima, the floor for you.
Thank you, Dr. Mariam, for this nice introduction. And assalamu alaikum, everybody. Thank the organizing committee for asking me to speak today. And thank you, Dr. Shabeen, for organizing this talk. Well, before starting, I would like to wish from Jordan, the river of Jordan, the place of the Jesus baptism, for all those people who are celebrating Christmas. Merry Christmas for everybody, and hope the situation will improve to allow Muslims and Christians to visit the holy site and the holy places in Jordan. My talk will be today about inertia in screening and diagnosis of hyperglycemia in pregnancy. Before going further, I would like to define inertia, which was established. The concept of inertia was introduced by Phillips when he introduced the idea of clinical inertia. The idea of clinical inertia, the best example for that is when the diabetic patient on oral hypoglycemic agent, let's say on 2 oral hypoglycemic agent, and his hemoglobin A1C is still high, but it takes years for the physician to increase or to add on medication to control his diabetes. After 7 years, Guy Goulin introduced the idea of diagnostic inertia. In another word, when the patient has a positive screening result, but he is labeled as not sick by his physician. The scope of hyperglycemia, everybody knows about. There are 21 million live births worldwide, globally, suffering from hyperglycemia in pregnancy. In another word, 1 in 6 live births are affected by hyperglycemia in pregnancy, in which 80% are due to gestational diabetes. Inertia in the diagnosis of hyperglycemia may have fetal and maternal consequences. By early detection and treatment, the outcome of affected pregnancy are improved and there are reduction of adverse event and complication, as Professor Mohan showed you. The primordial prevention of inertia, we can divide them to 3 levels: primary prevention, it's like a stitch of a time. This is to prevent and identify pregnant women having abnormal values. The secondary prevention include early detection of existing disease, timely screening and diagnosis, and prevention of development of complication in these women. And tertiary, not all is lost. The level of prevention involves regular screening in the presence of pre-existing complication to prevent further complication. Now, fundamental question which occur while dealing with hyperglycemia in pregnancy is there are so many different opinions between physicians and guidelines regarding diagnostic strategy. Inconsistent in the GDM diagnostic strategy between guidelines has led to challenge in making the diagnosis, in particular, how, who, and when to screen for hyperglycemia in pregnancy. Why is that? Because since 2013 until 2018, there has been more than 16 clinical guidelines in English language alone has been published talking about gestational diabetes and hyperglycemia in pregnancy. The inconsistencies include timing of screening, whether to use one-step approach, two-step approach during oral glucose tolerance test. Well, in the IDF, in the MENA region, after all these conflicts that occur, we are saying, we decided with Professor Shabin, the chairman of the guidelines, and and the collaboration with Professor Jamal Belkader, we decided to write guidelines in specific for the region, talking about hyperglycemia in pregnancy. Those guidelines were in contribution of 29 different authors from all over the MENA region. These were the first comprehensive evidence-based guidelines from the MENA. It is by multidisciplinary group of HCPs, uniform strategy for screening and diagnosis for hyperglycemia in pregnancy. And the format is clear, user-friendly, and pragmatic recommendation for clinical practice was clear. Now, who should be screened for hyperglycemia in pregnancy? Well, if we go about talking about risk-based screening may appear reliable, cost-effective, and easy to implement. However, most of studies reveal that risk-based screening can miss a lot of cases. European study showed that risk-based screening can miss 20 to 16% of gestational hyperglycemia in pregnancy. A study done in Pakistan showed around 26% of women were diagnosed with gestational diabetes without non-risk factor, as well as in Malaysia, around 24% of women with GDM didn't have any risk factor. And the American study found that if we use risk-based screening, we can miss half the cases of hyperglycemia in pregnancy. So we adapted universal screening, and because in the MENA region, the population are composed of multiple ethnic groups, and with the high prevalence of diabetes and obesity in our region, the universal screening is the best approach. So the best strategy to ensure maternal and prenatal well-being and prevent further complication in low-resources countries, such as the MENA region, is to adopt universal screening. So when to screen, as you can see, most of the guidelines, they advocate early screening to detect diabetes and pre-diabetes. But we advocate early screening to detect diabetes, pre-diabetes, as well as early gestational diabetes. Why we choose to screen at the first trimester, although there are large variation in recommendation, as Dr. Mohan said, because the majority of the guideline recommended universal screening for type 2 diabetes and pre-diabetes according to the WHO criteria. But the aim of early screening is to detect GDM as well as undiagnosed pre-existing diabetes and early GDM, as Professor Mihan has illustrated now, carries increased risk of hypertension, preterm birth, and prenatal mortality. And early interventions allow us to decrease the complication that can occur, mainly the macrosomia. So justification of early screening is very important in the MENA region. Second trimester screening, everybody, all the guidelines adopted the second trimester screening between 24 to 28 weeks of gestation, but we recommend as well third trimester screening if the second or the first trimester were missed, or the woman has sign of hyperglycemia during her third trimester, and to do the third trimester screening. What type of screening? One-step or a two-step approach? We choose the two-step approach because the one-step approach, the two-step approach has disadvantage in our place. It's higher missed causes, loss of follow-up because the lady has to come twice. Although she can, first time she can't come in non-fasting state, but she has to come for another fasting in a fasting state. One-step approach, the advantage, it is simple to follow, easier to diagnose, identify more GDM cases. The only disadvantage, that lady has to come in a fasting state, and there are some greater false positive tests. So we recommend the one-step approach. Alternative option for the MENA, if the pregnant woman cannot come in a fasting state, we can use DIPSI method, diabetes in pregnancy study group of India. It is a non-fasting 75-gram oral glucose tolerance test. If the pregnant woman cannot tolerate the glucose solution, we can depend on fasting blood glucose alone, and fasting blood glucose alone above 92 milligram per deciliter has a specificity of 100%. So it can be a reliable test, easy to apply, and there is no need to drink glucose solution as well. And it decreases the oral glucose tolerance test that is required, decrease the oral glucose tolerance, because if the patient is positive, no need to proceed for oral glucose tolerance test. Hemoglobin A1C is not recommended as a screening test for gestational, but only can be diagnosed for pre-existing diabetes. Another thing very important, that we emphasize the point that if laboratory facilities are not available, so the handheld plasma calibrated instrument can be used to evaluate blood glucose level. In summary, it is very important to diagnose hyperglycemia in pregnancy in a timely fashion. Inertia in the diagnosis of hyperglycemia may have their effect on the fetal and maternal consequences. By early detection and treatment, the outcome of affected pregnancy are improved, and reduction of adverse event and complication. In order to avoid inertia and screening, we have to simplify, and clear guidelines needed to be widely available for everybody, easy to apply, and organization for the organization involved in the pregnancy, and to do the screening at the first prenatal visit, universal screening for all pregnant women, and if negative, repeat the test at 24, 28 weeks of gestation. And the recommended gold standard test is 75-gram oral glucose tolerance test, depending on the situation. Thank you.
Thank you, Dr. Nadima. Now we have the last lecture with Professor Shabin Naz Masood. She is a professor at the Department of Obstetrics and Gynecology, ISRA University, Karachi campus. She is a visiting consultant for diabetes and in pregnancy and diabetes association of Pakistan, WHO Collaboration Center, and member of governing body. She is a constitutive member of Diabetes in Asia Study Group, also a member of governing body of Health Research Advisory Board of Pakistan. At present, she is chairperson of Insulin Sensory Working Group of MENA and authors of many research publications medical in many journals. She was heading the project of gestational diabetes mellitus prevention and control program in Pakistan. Her topic, very interesting and rarely discussed about sexual dysfunction in diabetes. Dr. Shabin, the floor is for you.
I begin my presentation in the name of Allah, the most beneficial, the most merciful. Bismillahir-Rahmanir-Rahim. So I shall be talking about female sexual health in diabetes, which has definitely been ignored since a long time. And I'm talking about diabetes related sexual issues. And if we visit any conventional diabetic clinic, we come across screening, testing, diabetes eye clinic, kidney dialysis, diabetes foot care, and also diabetes educators and dietitians are now new additions to most of the clinics and most of the diabetes centers. But when it comes to female sexual health concerns, we hardly see any corner or any room which is designated to this particular issue. And sexuality, an aspect of quality of life, has not gained any attention in clinical care. And we very well know that human sexual function is an essential component of life, both in species propagation and also for the quality of life. And lack of privacy to women, lack of acceptance by healthcare providers that sexual diseases matters to women with chronic illness is the main reason behind this. With the advent of insulin, it's more than 100 years now of the insulin. But in the next few decades, literature focused on the effect of diabetes on maternal and perinatal complications. There has been a complete neglect on the influence of diabetes on both male and female sexual functioning. Impaired sexual function in men is a well-documented complication of diabetes and was first announced by Avicenna, the Persian physician and philosopher in 10th century AD. But when it comes to the sexual problems of women with diabetes, the things are less clear and have received less attention than those of men. So both of them are said to be suffering from the complications of diabetes at an equal length almost. So discussing sexuality is unheard of. The philosophy behind this is that if you don't ask about it, it doesn't exist. In women, even today, sexuality is still often viewed as equal to reproduction, which leaves the sexual issues unaddressed. Issue of sexuality is a taboo in society even today. Jocelyn did mention impotency, but did devote an entire chapter to marriage, but he did not mention impotency in his book, which was dedicated to doctors and patients of diabetic manual. And he said that no diabetic boy or girl should get married until they are ready to face the problems of diabetes with a smile. Marriage involves no danger for men, but parturition does involve danger for the women. He further advised that two diabetics should not marry and have children. This Masters and Johnsons, they developed the linear sexual response model for men and women that included desire, arousal, orgasm, and resolution. And they belong to the Department of Obstetrics and Gynecology in St. Louis, Washington University of St. Louis. Why was this sexual cycle response important? It was an important educational tool that clinicians can use when counseling women with sexual concerns. A woman may engage in a sexual encounter for a number of non-sexual reasons. For example, to please her partner, to feel emotionally connected, or out of a sense of duty that since he is earning bread and butter for the family, this is imperative for the woman to gratify him with sexual response, whether she wants it or she does not want. There are cultural differences in female sexual dysfunction. 43% of the women in developed countries and 25% of the women in Asian countries consider it as embarrassing, and it is they think that it is a private topic to discuss, and hence sexual problems go unnoticed. Besides, doctors' limited experience and comfort in handling sexual problems can impede the uncovering of possible sexual difficulties or disorders. And on the part of the patients or women, personal taboos regarding sex, confidentiality issues, and worries about potential humiliation, that doctors would say that please look at your medical condition and later we'll talk about sex. And time constraints and communication, rather poor communication skills of doctors. The juniors, they don't have skill, and senior doctors, they don't have time to talk to. Considering all these factors, a cross-sectional multi-center study was designed by our group about the frequency of sexual dysfunction in women with diabetes. And the good news is that this study has been accepted for publication in Journal of Diabetology. In this study, I'll share just a few slides. We shared female sexual dysfunction index, and that was modified, and that was also translated in local language. I will just share a few slides, as I said. We asked about awareness about diabetes, and 68% of the respondents, they said that they received awareness about diabetes, and 48% of them, they received it from healthcare professionals. Let me share that all these interviews were conducted by a senior person of our faculty, that is our assistant professor of obstetrics and gynecology department, and all the women, they were coming to the diabetic eye clinic in one of the centers, and in other centers, they also were attending the diabetic clinics. So awareness about sexual relationship, when they were asked, 98% of them, they said that they had sexual issues, but only 9% said that they'd ever discussed the sexual issues with their healthcare providers. Prohibitors or deterrents of sexual relationship were children, small house, busy schedule, weakness, and pain. All these deterrents, they led to lack of sexual desire in 43%. When it came to the female sexual cycle response cycle, then in that case, you can see that dyspareunia, orgasm, and lubrication problems were there in 81 to 84% of the women, but sexual desire and arousal was present in 75% of the women. And this is the area which is more difficult to treat as compared to lubrication, dyspareunia, and orgasmic problems. Women reported being more likely to disclose information about sexual health if providers did not make assumptions, appeared non-judgmental, and comfortable to talk and respectful. Now, coming to the prevalence of female sexual dysfunction, it has a wide range between 25 to 71%. This is because of lack of standardized definition and data free of socio-cultural context. There are a number of definitions. The revised definition of female sexual dysfunction by American Psychiatric Association says all diagnoses except substance and medication-induced sexual dysfunction now require a minimum duration of approximately 6 months, as well as the presence of symptoms 75 to 100% of the time. So a duration of 6 months is accepted. Now, what does data suggest from clinical trials conducted over 5 decades? There has been a number of studies which started from 1971. Claudie was the first to discuss, and the summary of these trials, they suggest that the age that diabetes most frequently affects sexual arousal Dyspareunia was one of the reasons, and the age, diabetes duration and control, as well as its complications, have not been associated with female sexual dysfunction. The studies which were conducted after 2010, they focused more on the organic factors and psychological factors. A number of studies, they all were focused on these cultural and social and psychological factors. So diabetes and its effect on women's sexual dysfunction are multifactorial. They are interpersonal, psychological, social, biological, and pharmacological therapies. The psychological factors, they include anxiety, depression, altered body image, and the biological factors, they include pregnancy, pelvic floor dysfunctions as a result of delivery, and also menopause. Pharmacological therapies, obviously antidepressants and some of the side effects of anti-hypoglycemic drugs. There is a prevailing view that sex is the prerogative of young, fit, and attractive. Doctors need to recognize that people may be sexually interested even though they are old, ill, or disabled. As far as the treatment is concerned, there are no specific guidelines for the treatment of female sexual dysfunction in women with diabetes. And then female sexual dysfunctions do not have a strict medical origin. Mistaken diagnosis may further complicate the management. Pharmacotherapy alone, without addressing psychosocial issues, have been proven to be unsuccessful. So lifestyle modification can improve female sexual function as well as the diabetes, control of the diabetes and blood sugar. Most relationships suffer silently due to unspoken sexual problems between the couples. So for that, couple therapy or mindfulness is advisable, and couple therapy for greater partner intimacy, and this is to assess the adaptation to chronic illness. Both the partners are interviewed together or separately. The interviewer may not be the doctor who is providing them the medical care. Besides cognitive behavioral psychotherapy for desire disorders and businessness are there, and this is to change the catastrophic self-view imposed by the illness on the woman, and this is to break the thoughts, feeling, and behavior cycle. The thought is that sex is for well women, and if she is not able to procreate, she is no more attractive, and people would not be interested in sex with her. So we have to break this cycle of thoughts, feeling, and behavior. Potential therapeutic options available for the treatment of female dysfunctions are many. And first of all, we'll talk about Osphena. It is an estrogen receptor agonist with tissue selective effects, and that has been approved for treatment in 2013. And this is meant for the treatment of mild to moderate dyspareunia. Another therapy is Premarin cream for local application. This increases the superficial mucosal layer of the vagina, increases the pH, elasticity, and lubrication. So in postmenopausal women, especially Premarin, that is a conjugated estrogen, may be applied locally, and that may be of help, but this needs a longer duration of treatment for it to be effective. Tibolone, that is available by the name of Levial, again, hormone replacement therapy in postmenopausal women, has been shown to improve desire, arousal, and lubrication. Phentolamine is an alpha-adrenergic blocker that blocks alpha-1 and alpha-2 and has no effect on beta receptors. This improves arousal and lubrication, and the dose is 40 milligrams. Elamucil and other patented nutritional supplements are available in the market. Bupropion in a higher dose, like 150 milligrams twice daily, has been shown to be effective as an adjuvant for antidepressant-induced sexual dysfunction. Then comes the sildenafil and tadalafil. That is Viagra. Viagra Pink is available for female sexual dysfunction. The action of sildenafil is 4 to 5 hours, and the tadalafil has a longer duration of action of 36 hours. So this is better, better drug to be prescribed as compared to sildenafil. When the sexual act is intended, then tadalafil may be taken in a dose of 20 milligrams. And this is more beneficial for the women who have been taking antidepressants with high serotonin levels. Double-blind crossover placebo-controlled study shows the action of phosphodiesterase type 5 inhibitors that are useful for sexual arousal and orgasmic disorders. And this placebo-controlled study that shows that in the dose of 50 milligrams is as effective as 25 milligrams of the dose for sexual arousal and disorder. The thing here is that in the end, I would say that recognize the fact that women with diabetes are at increased risk for sexual dysfunction. Sexual dysfunction can have a high psychological burden and negative impact on marital relations, already burdened by the presence of chronic illness. And for doctors, we must be aware that sexuality is often a subject about which patients do not volunteer information. And we have to think about our capabilities and comfort to initiate the discussion to inform and manage sexual problems of the women. And we have to prevent discouraging people who dare to bring up questions about sexual issues. We must learn to get rid of old beliefs and thoughts. Walking and climbing uphill with a burden of old beliefs is almost impossible. In the end, I would again like to extend my gratitude to Professor Jamal Belkader, Dr. Mohan, Dr. Nadima, Hana, and Mariam for being with us. Thank you, IDF MENA Congress 2021. Thanks to all the listeners for bearing with us for this 1 hour. And if there are any questions, I would request Dr. Mohan and Nadima to take care of them on my behalf. Thank you very much.
Thank you, Professor Shabin, for your excellent topics. And I will take the opportunity to thank for all your effort and support the MENA region, IDF, and all regarding the pregnancy and diabetes and pregnancy, and establish the guideline with the team, your team. So I would like to, on behalf of MENA region, would like to thank you a lot. We'll open the floor for discussion. I will give my colleague, Dr. Hana, for to open the floor for discussion. Dr. Hana?
Yes. We are ready for having questions. Just in between, many diabetic men ask for medical advice for sexual dysfunction, but it is a forgotten problem for a woman, diabetic woman. It's an important issue. Thank you, Dr. Shabin.
So the question is, are there any age specification for the pharmacological treatment of sexual issues? This is Dr. Shabin.
Thank you very much for the question. First of all, greetings to our friends for Christmas, as Dr. Mohan very rightly said. And it was a pleasure to listen to, always a pleasure to listen to Professor V. Mohan and Nadima. Thank you, Hana, and thank you, Mariam, for your nice coordination. Can you all hear me?
Yes.
Yes.
Go ahead.
Thank you.
The question again.
About, yeah.
Yes.
The question that comes is that whether there is an age, there is an age and the difference in the medication according to age. Actually, there are few medications which are age related. For example, in postmenopausal women, where there is relative vaginal mucosal atrophy, we prefer to give Premarin and Ospin, as I just said, but not so in younger couple. So what is important is medication is less important as compared to psychotherapy in most of the patients. Age-specific medications are there, but as far as doses are concerned, they are almost all the same. Only the age-specific things would start in postmenopausal women when it comes to hormone replacement therapy or local application of creams like Premarin, as I said earlier. So thank you very much for this question.
Thank you, Professor Shabin. The second question from Dr. Rahul. He writes that speaker name Hana Al-Qanim. This is the question. Dr. Hana, she's not the speaker. But the question regarding the medication is SGLT2 and women hygiene. Any comment? This is the second question. Can anyone answer this question for Dr. Rahul?
Well, I can if Hannah is not going to answer.
Yes, Dr. Nadim. Nadima, you can answer.
SGL2 propose women to urinary tract infection and vaginal infection. So it's advised of anyone who is on SGL2 to drink plenty of fluids and to avoid not going to that frequently to empty the bladder. Other than that, the hygiene is required for anyone, either in SGL2 or not, but no specific hygiene except drinking a lot of water and avoid infection. But if infection occurs while drinking the SGL2 and recurrent infection, urinary tract infection or vaginal, the drug has to be reconsidered.
Thank you, Dr. Nadima. The third question from Dr. Abdul Wahab Sulaiman for Dr. Professor Mohan. Why we need to screen again for GDM on the 24th week of gestation? Would that change management and we are going to screen them in postpartum period? So, Dr. Mohan?
Yeah, thank you for that question. If they have early GDM and it is severe enough and the treatment is started, there is no need to screen again for GDM because they might have been started on diet or insulin. So again, we don't have to screen them at 24 to 28 weeks. But suppose they don't have early GDM and the fasting blood glucose is below 92 in the first trimester, then we have to do an OGTT in the second trimester, 24, 28 weeks. And that is the guidelines of all the international associations, including the IADPSG. So you're quite right that if they've been started on treatment, the values could have changed. The reason why we are doing this in our study is because there are no strict guidelines as to what to do with the early GDM. So that has not yet come. I think after the Tobogum study, that may come, but right now we don't have it. And therefore, we were just testing to see whether how many of them will have GDM in the second trimester when we test. Quite surprisingly, what we find is that while a good number of them have the GDM in the second trimester also, some of them revert back to normal. This could be because they went on a diet or they tried to start more exercise or something like that. Or it could have been a very minor abnormality. We are saying above 92 is GDM. Sometimes it could have been 93. And so we'll label them as having GDM. And the next day, if you do it, it may be 90 or 89. And it can come normal because lab variations and the sugar variations from day to day, you don't get the same reading every single day if you do it. And especially if they have gone off sugar, the moment the lady knows she has some sugar abnormality, she's going to completely stop sugar. So it is possible that it becomes normal. So that is the reason why as a trial part, we are just testing it and seeing what happens in the second trimester. Unfortunately, HbA1c is not useful because HbA1c, as pointed out by Dr. Nadima also, is very insensitive. So either in the first trimester or even in the second trimester, A1C is totally useless as a screening test. It may show 0.1 more or something, which you cannot pick up in a routine individual case. So that's the reason why we screen in the second trimester.
What's regarding postpartum period? You mentioned that this will change in postpartum period.
Yes.
I think in postpartum also we need to screen them after delivery.
Definitely.
Because some of them, they will get the second type 2 diabetes.
Yes.
Will continue. So it is very important to check after delivery also.
So the question which is not answered is it the same risk if you get conventional GDM 24 to 28 weeks for converting to type 2 diabetes, or if you get early, is it the same risk? We don't know, because such studies have not been done. The toboggan study is again doing it. The STRIDE study also, we have data. We have fairly large numbers of both early GDM as well as conventional GDM. So as you're following them up, now the women are being followed up, that data will emerge. Right now, we don't know.
Thank you, Dr.
Shabin. We have
yes.
Okay, Dr. Shabin, we have a question from Dr. Elirza. She's asking the best treatment for vaginal lubrication in diabetic patients.
The answer is that if the woman belongs to, if the woman is not if she is not menopausal, then in that case, just the lubricants like KY gel, that can work well. But if she already is entering the premenopausal, perimenopausal, or menopausal phase, then in that case, as I said earlier, that pre-menopause cream is of great use. That is a conjugated estrogen cream, and that enhances the vaginal, mucosal, vaginal mucosa, improves pH, and then the lubrication of the vagina is better. In those cases, when the woman is perimenopausal or then has entered into menopause. This is true for diabetic as well as non-diabetic people, non-diabetic women. So lubricants, they work well, but it must be remembered that if a woman is desiring the fertility, then these lubricants can reduce the fertility because they do not allow the sperms to propel forwards. So in that case, the lubricants must be used judicially.
This is a question. We have a huge number of pre-diabetes and fertility age. Where do they fit in for diagnosis of GDM? Some of them are on metformin already.
So we'll have to treat
Dr. Mohan?
Yes, we'll have to treat them as pre-gestational diabetes. So if they're already having pre-diabetes, you're already on metformin, then they must be having fairly severe pre-diabetes, although not quite in the diabetic stage. Gestational diabetes, by definition, has to be glucose intolerance, which comes during pregnancy. If they've had it outside of pregnancy, it's pre-diabetes complicating pregnancy. If they had severe, they had overt diabetes, it's diabetes complicating pregnancy. So these will come under pre-gestational diabetes. It will not come under gestational diabetes.
Okay, thank you.
Thank you, and hello, everybody. The field of diabetes care is rapidly changing as new research, technology, and treatments that can improve the health and well-being of people with diabetes continue to emerge. And with the annual updates since many years, the American Diabetes Association has long been a leader in producing guidelines. So with these topics, with Dr. Muhammad Sulaiman and Dr. and Professor Adel Al-Sayed, we can and we try to highlight these recommendations. Before this, and without too much delay, I give the floor in order to clarify the other highlights to Dr. Muhammad Sulaiman from Sudan. In fact, Dr. Muhammad Sulaiman is graduated from the University of Khartoum, Sudan, and trained in general medicine, diabetes, and endocrinology in the United Kingdom to obtain the certificate of completion. He did endocrinology research with culminated in achieving a doctorate of medicine from the University of Sheffield from United Kingdom. He worked as a consultant endocrinologist in the United Kingdom before joining the Imperial College London Diabetes Centre in Line as a consultant endocrinologist, and currently the lead doctor for medical guidelines at Imperial College London Diabetes Centre from Abu Dhabi and Line from Emirates. So it's for you, the floor, Dr. Mohammed Suleiman.
Okay, well, thank you very much to the organizers for this meeting for inviting me to give this talk. So my task is to give highlights from the ADA 2021, which was last June, and the task is to give highlights in 15 minutes. So I had to be very selective. I don't have any conflicts of interest. So because I have to be very selective, this is the topics I chose for this presentation, and I put them in themes. So first of all, the type 2 diabetes therapy issues. I'm going to talk about the important study GRADE, and then the study SERPASS using tirzepatide. In type 1 diabetes, I'm going to talk about briefly about the drug called teplizumab for diabetes type 1 prevention. And in obesity issues, semaglutide high dose was assessed in a program called the STEP program. So I'm going to talk about that. And lastly, one COVID issue on the use of dapagliflozin in COVID, DARE 19 study. Okay, so we'll start with the type 2 diabetes issues and starting with the GRADE study. And I think really this is the most important presentation at the ADA meeting. So GRADE stands for glycemia reduction approaches in diabetes, a comparative effectiveness study. The GRADE study was led by this man, Professor David Nathan, as I'm sure many of you will know. He was also one of the leaders of the DCCT study, the Diabetes Prevention Program, and other big studies. So in this GRADE study, this is the first comparative effectiveness study of head-to-head of 4 anti-hyperglycemic drugs on top of metformin. The planning for this study was between 2009 to 2012, and the recruitment was between 2013 and 2017. Data collection ended in May of this year, and the preliminary results were presented at the ADA, and the final results presented at the EASD. So the GRADE study recruited just over 5,000 patients with type 2 diabetes. Their mean age was 57 years. The BMI was 34. Diabetes duration was relatively short at 4.2 years. And the baseline hemoglobin A1C was 7.5%. LDL cholesterol was well controlled at 91, and triglyceride level was average at 154. The GRADE study was done only in the United States of America. So 2/3 of the patients were white, 1 in 5 were blacks, and 14% were other ethnicities. And the population in this study were randomized to one of 4 drugs on top of metformin. So the GLP agonist liraglutide, the basal insulin analog glargine, the sulfonylurea glimepiride, and the DPP-4 inhibitor sitagliptin. The duration of follow-up, the mean duration of follow-up was 5 years, and the range was between 4 to 7.8 years. Some important omissions from the GRADE study were, first of all, the SGLT2 inhibitors were not included. Obviously, this is important. And the reason given by the authors of the study was that at the time the study started, in 2013, they were not yet licensed. The first SGLT2 inhibitor licensed by the FDA was in 2013, which was after the study started. Another important omission was the TZD's pioglitazone was not used, and the reason given was because at the time of inception of this study, there was actually a lot of debate of whether the TZDs were actually harmful in terms of cardiovascular risk. So all patients were on metformin. The mean dose was 2,000 milligrams per day. The primary metabolic outcome was the time to reaching hemoglobin A1C of 7% or more on a maximum tolerated dose of the drug they are allocated to. So it's a time to failure. The secondary metabolic outcome was reaching A1C of 7.5% or more on the maximum tolerated dose before going to glargine in the groups were not randomized to glargine. And the tertiary metabolic outcome was the time to reach hemoglobin A1C of 7.5% or more after adding glargine. And these are the results. These are first the metabolic results of the GRADE study. So the drugs that reached the metabolic outcome in a short time did badly, and the drugs that took longer to reach the metabolic outcome were the ones that did well. So the time to reach the primary metabolic outcome was similar between liraglutide and glargine at 2.4 years. Slightly shorter with glimepiride, the sulfonylurea, and much shorter with the DPP-4 inhibitor sitagliptin at 1.8 years. So if you compare the different drugs, liraglutide was similar to glargine. There was only 21 days difference between them, but liraglutide reached the primary outcome longer than glimepiride by 72 days and by 185 days longer than sitagliptin. And if you look at the secondary and the tertiary outcomes, more or less they were similar. Looking at microvascular complications in this study, they looked at nephropathy and neuropathy, and there was actually no difference between the 4 drugs. When you look at the macrovascular outcomes, they lump together all the cardiovascular outcomes, and when comparing the different drugs, liraglutide actually did better than the other 3 drugs in terms of the combined cardiovascular outcomes with a p-value of 0.048. When you look at MACE, the 3-point MACE, or hospitalization for heart failure or mortality, there was actually no difference between the 4 drugs. However, there was a trend for a better outcome with liraglutide compared with the other 3 drugs. In terms of adverse events, all 4 drugs were actually very well tolerated. Severe hypoglycemia was reported by only about 1.4% of patients treated with glimepiride, and slightly less than that in patients treated with glargine. As expected, there were more GI side effects with liraglutide, and interestingly, there was actually no excess weight with glargine. GRADE study is quite a large study. A huge amount of data has been collected. So in the future, they want to look at these issues. So prediction of response by phenotype, pharmacogenomics. So we will have a lot of data on the popular theme of precision medicine to guide our use of drugs after metformin. They collected data on 1,700 patients who used continuous glucose monitoring. So that would be very useful to look at. And they also plan to look at quality of life and very importantly, cost effectiveness differences between the 4 drugs. So that a rich amount of information is available to look at. So the take-home message from the GRADE study is that the GLP agonist liraglutide was actually the best among 4 drugs, which was followed by glargine. But the DPP-4 inhibitor sitagliptin had the worst outcome. There was a quite interesting discussion after the presentation of the GRADE study, and perhaps the consensus from the discussion was that maybe the DPP-4 inhibitors do not really deserve to be at the same level with the other drugs. And these are the reasons. They did badly. They had the worst metabolic outcome in the GRADE study, but also in the cardiovascular outcome trials, although they were safe, they did not actually have any extra cardiovascular benefits as opposed to benefits with the SGLT2 inhibitors and the GLP agonists. And of course, they still have a high cost. So that's about the GRADE study, a very important study, and I'm sure we'll hear more about it. Moving on to another study in type 2 diabetes. This is a SURPASS series of studies. And this was a series of studies, phase 3 studies, looking at a new compound called tirzepatide. This is a combined GLP-1 and GIP agonist, looking at its efficacy and safety in patients with type 2 diabetes. So in the ADA, 4 results were presented, SURPASS 1, 2, 3, and 5. And in all these 4 studies, they compared against comparators 3 doses of tirzepatide, 5 milligrams, 10 milligrams, and 15 milligrams. And in all the 4 studies, the primary endpoint was change from baseline hemoglobin A1C. And the baseline characteristics for the 4 studies were around this. So mean age was between 54 to 60 years, BMI 32 to 34, hemoglobin A1C of 7.9 to 8.3%. And this is a summary of the results of the SURPASS studies. So in SURPASS 1, this is monotherapy study against placebo. In SURPASS 2, this is patients who are already on metformin randomized to tirzepatide or semaglutide 1 milligram, which they said was the strongest available GLP agonist. In SURPASS 3, patients who are already on metformin plus or minus an SGLT2 inhibitor were randomized to either tirzepatide or the basal insulin analog degludec. And in Surpass 5, these are patients who are on glargine and metformin, and they were randomized to either tirzepatide or placebo. The duration of the studies was between 40 to 52 weeks. And this is, if you look at the last column there, these are the results summarized. And this is just for the high dose tirzepatide 50 milligrams. And the results for the other doses were similar or close. So for the highest dose, the A1C reduction was quite robust with tirzepatide 50 milligrams between 2.1 and 2.6%. And the reduction in weight was, again, was very impressive, between 9.5 kilograms up to nearly 13 kilograms. So very robust weight reduction and A1C reduction with this compound. So for the 4 studies, tirzepatide was actually shown to be superior to all the competitors in both hemoglobin A1C reduction and in weight reduction. And in terms of adverse effects, they were GI side effects, of course, but they were actually similar to what you expect with the other GLP agonists. So, there are other ongoing studies with tirzepatide. So there is a cardiovascular outcome study comparing with the dulaglutide. There is a study in obesity, excluding patients with type 2 diabetes, called SURMOUNT-1. And there is a study in fatty liver disease. So a lot more to expect from this compound. So the take-home message from the Surpass studies is that this new GLP-1 GIP agonist is actually quite effective, demonstrated robust reductions in both A1C and weight lowering. And this is actually quite clearly more than what we see with the current GLP agonists, and the safety profile is similar to the GLP agonists. Okay, so now moving on to some issues with type 1 diabetes. So a drug called teplizumab, many of you may remember, there was a study published in 2019 which showed that this drug can actually delay the progression to type 1 diabetes in high-risk patients. And what was shown in the ADA of this year was an extension to that study, which showed that teplizumab delayed the development of type 1 even more. So it was 32.5 months, about over 2.5 years in the delay in the meantime to diagnosis of type 1 diabetes. And so following this, teplizumab has been shown to be the first drug to demonstrate preservation of the beta cell function and leading to delay in onset and potentially prevention of type 1 diabetes. And following this study, the FDA Advisory Committee actually voted in favor of teplizumab use to be expected to be approved for preventing type 1 diabetes in high-risk patients. Now moving on to some obesity issues, semaglutide high dose was used in what's called the STEP program. So this is 4 studies were presented at the AD meeting, STEP 1, 2, 3, and 4. Looking at high dose semaglutide in patients with obesity. So step 1 was in patients with obesity without diabetes, comparing semaglutide 2.4 milligrams against placebo. Step 2 was in patients with type 2 diabetes and obesity. So comparing high dose semaglutide 2.4 milligrams against low dose semaglutide 1 milligram against placebo. Step 3 was in patients with placebo, comparing semaglutide 2.4 against placebo, but this is in patients who already received low-calorie diet and intensive behavioral therapy to see if the effect of the semaglutide will be additive on top of that. And in step 4, all patients were given 2.4 milligrams semaglutide for 20 weeks, and then they were randomized to either continuing semaglutide or changing to placebo to see whether the benefits were sustained. All the 4 step studies ran for 68 weeks. The mean age was between 46 to 55 years, and the mean BMI was between 36 to 38. And this is a summary of the 4 step studies. So if you look at weight reduction with semaglutide 2.5 milligrams, again, very robust weight reduction ranging between 10% of baseline body weight up to 19% of baseline body weight. This is a huge amount of weight loss. Those who achieved at least 5% or more of reduction in weight from baseline were between 69% and 87%. Again, very robust. And if you look at the last column there, if you look at least step 1 and step 3, a third of these patients achieved a weight loss of 20% or more. So this is really the sort of weight reduction we see with bariatric surgery. And this has not really been seen by any obesity drug before. So this is a huge amount of weight loss with this drug. In terms of adverse events, again, there were some GI side effects, but were actually similar to what you see with the other GLP agonists, and there were no new identified risks. So following these studies, semaglutide 2.4 milligrams weekly has actually been approved by the FDA as a treatment for obesity from last June. So the take-home message is that semaglutide 2.4 milligrams weekly is quite effective and showed very robust weight loss, and it's actually also safe as an obesity treatment. And the last issue I wanted to talk about is a COVID issue, looking at this study that looked at dapagliflozin in patients with COVID-19. So just to give a background to the rationale about thinking about this study. So if you think about patients admitted with COVID, severe COVID to hospitals, the studies showed that these patients had reduction in endothelial function, increased oxidative stress, increased inflammation, increased insulin resistance. And the studies in COVID, people who did badly in terms of morbidity and mortality, there were more patients with hypertension, type 2 diabetes, heart failure, CKD, obesity. And if you look at the cardiovascular outcome trials with the SGLT2 inhibitors, what has been shown in these studies is that these drugs improve endothelial function, they reduce oxidative stress, they reduce inflammation, they reduce insulin resistance, and obviously the studies showed that SGLT2 inhibitors have a benefit on blood pressure, on glycemia, they improve heart failure, CKD, and so on. So the theory was maybe the SGLT2 inhibitors may have beneficial effects in patients admitted with severe COVID, and they may reduce morbidity and mortality. So that was the rationale behind it. So DARE 19 managed to randomize 1,250 patients hospitalized with COVID-19, and they were randomized to either dapagliflozin or placebo. The mean age was 61 years, 42% were females, and actually half of them were diabetic and half were not diabetic. And this is a result of the DARE 19 study. So the primary outcome, which was the time to organ failure or death at 30 days, was actually numerically lower with dapagliflozin, but it did not reach statistical significance. The hazard ratio was 0.80 with a confidence interval including 1 and a non-significant p-value. So the take-home message was that dapagliflozin given to patients admitted with COVID-19 and cardiometabolic risk factors did not actually reduce organ failure or death, but however, it was actually safe to give it. And this is important because many of you will remember in the early days of COVID, there was a suggestion that maybe when diabetic patients on SGLT2 inhibitors are admitted with COVID, maybe we need to stop SGLT2 inhibitors because they may have adverse effects because of their effects on hypovolemia and so on. But this study showed that they're actually they are safe to give in patients with severe COVID. So my final take-home messages, I think the main message for me from the GRADE study is that the DPP-4 inhibitors did badly and the SGLP agonists did well. From the SURPASS studies, tirzepatide had robust effects on A1C and weight, so we need to watch out for this important compound. Teplizumab was the first drug to be licensed for prevention of type 1 diabetes and has already been licensed. Semaglutide has shown robust effect on weight in patients with obesity, so this will be a welcome addition to treatment of obesity. And lastly, maybe we don't need to stop SGLT2 inhibitors in patients admitted to hospital with severe COVID. Thank you very much.
Okay, thank you. Thank you very much, Professor Mohammad Suleiman, for your excellent talk. Now, with permission of Dr. Fatma Munif, I may introduce our second speaker, Professor Adil Al-Sayed. If I read his, am I audible? If I read full CV of Professor Adil Al-Sayed, then it may take half an hour, which we cannot afford. If I read the CV given to me, it may also take more than 5 minutes. So I will read on the highlights of CV of Professor Adil Al-Sayed because everybody knows him very well. Professor Adil Al-Sayed is Professor of Internal Medicine and Diabetes. He is WHO Diabetes Consultant. He is the committee which produced the WHO International Diabetes Treatment Guideline, which was published in Annals of Internal Medicine Journal. He is past chair of Middle East and North Africa region, IDF. He is the current president of Egyptian Non-Communicable Disease Alliance, which is a member of Global NCD Alliance. He is a member of advisory board of 5-year project Type 2 Diabetes Mellitus Prevention Development Impact Bond for Diabetes Prevention among Palestinian refugees, which is carried out by United Nations Relief and World's Agency. He was a principal investigator for Image Egypt study about primary prevention of diabetes in Upper Egypt in collaboration with Dresden University, Germany. He is a member of IDF International Expert Committee for GTM Wings Project of India. He is a contributor author of 6th edition of IDF Diabetes Atlas 2014. So, mic over to you, Professor Adil Al-Sayyed.
Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah ar-Rahman ar-Rahim. First, I would like to thank Professor Jamal Al-Khadir and the whole organizing committee for asking me to speak about important topics discussed during the virtual 2021 ESD conference, which was held at the beginning of last October. Of course, as Dr. Muhammad Suleiman rightly said, I cannot cover the whole conference in 15 minutes. So I chose to cover one important topic, which is obesity, just to see what was new regarding obesity during this important event. Obesity is an important field which has recently been a focus of growing interest for the whole diabetic scientific community. And these are the topics I found regarding obesity in the ESD conference. It's obesity in type 2 diabetes, obesity in type 1 diabetes, metabolically healthy obesity, and recent news about obesity and diabetes remission. Now, let's have a look to what is new about obesity in type 2 diabetes. It is now clear that type 2 diabetes is a heterogeneous group of diseases. This is an introduction to the topic. Type 2 diabetes is a heterogeneous group of diseases regarding their progression, prognosis, therapeutic needs. So, in addition, there had been many discoveries have recently been made in genetic characteristic and pathogenetic mechanisms of type 2 diabetes. And these data had led to a new proposal regarding type 2 diabetes classification, which has been introduced by Stockholm University Group during the last couple of years, and is now being widely internationally accepted. This classification, they classified type 2 diabetes into severe autoimmune diabetes, severe insulin deficiency diabetes, severe insulin resistance diabetes, mild obesity-related diabetes, and mild age-related diabetes. 3 severe and 2 mild forms of diabetes with different pathogenetic mechanisms. What is new regarding that in the recent conference is that there was another proposal which had put obesity right in the center of the approach and had recommended that weight loss should be a primary goal in type 2 diabetes treatment. And according to the estimates included in the Lancet and presentation of that topic, 40 to 70% of people with type 2 diabetes have obesity, and about 20 to 40% have cardiovascular disease. So this leads to 3 subgroups of people with type 2 diabetes: adiposity-related diabetes, diabetes with cardiovascular disease, and isolated hyperglycemia. And the treatment should be tailored specifically towards those subtypes. The proposal is to adopt a glucocentric approach for those with beta cell dysfunction and isolated hyperglycemia to reduce hemoglobin A1C to the determined target. And for those with cardiovascular disease should receive a cardiocentric approach with the use of proven cardioprotective agents and, of course, to target other cardiovascular risk factors. Everybody else have to receive a weight-centric approach with a low-calorie intake to get weight loss of 15% as a primary goal. And so weight loss of at least 15% of body weight should become initial principal treatment goal for many patients with type 2 diabetes, according to this proposal. And of course, this will lead to diabetes remission in many of those patients, and I shall be back to this issue before ending my presentation, because there's something important regarding exactly the same issue. Now, I shall move on to obesity in type 1 diabetes. We always talk about weight and weight management in the type 2 diabetes. Actually, in type 1 diabetes, obesity is important as well. Sorry, my computer is just running. In fact, a large proportion of people with type 1 diabetes is overweight and has obesity which exceeds that of the general population, and the rates appear to be rising. And the relationship between type 1 diabetes and obesity is bidirectional. So obesity itself can accelerate beta cell destruction. But meanwhile, obesity rapidly increases after initiation of intensive insulin therapy, leading to insulin resistance, necessitating higher doses of insulin and causing a vicious circle of insulin-associated weight gain, which is difficult to control. This relationship stimulated development of actions both in US and Europe. In US, they developed the Action Initiative, Advancing Care for Type 1 Diabetes and Obesity. It's a few years ago, and the aim was to identify acceptable and effective dietary strategies to optimize both glycemic control and weight management in young adults in type 1 diabetes. The new issue which was presented in the ESD conference was the SOFIA project. There has been a presentation on the recently established SOFIA project of Europe, stratification of obese phenotype to optimize future obesity therapy. And the aim of the SOFIA project was to improve our ability to predict who will experience which complications and who will respond best to different obesity treatment. One arm of the project will focus on the relationship between type 1 diabetes and weight. In this arm, they stated that people living with diabetes will be involved in all aspects of the project via a patient advisory board. Ultimately, the project results should provide the basis for treatment pathways that are accepted by people and healthcare professionals. More broadly, the project hopes to change the narrative around obesity, to make obesity more patient-centric and equitable, and to underline that it is a chronic disease. It's not something people can choose to live with. Obesity is a trait and has to be treated. There are challenges of obesity management in type 1 diabetes. The two newer drugs of type 2 drugs classes which have shown weight loss benefits, GLP-1 receptor agonists and SGLT2 inhibitors, are not approved in USA for type 1 diabetes. In Europe, the SGLT2 sotagliflozin and dapagliflozin are approved as adjuncts to insulin therapy in certain patients with type 1 diabetes. However, these drugs are underused in obese type 1 diabetes, basically because of their high cost. Now, let me move to metabolically healthy obesity. Metabolically healthy obesity is a term used to describe those who have a body mass index more than 30, but no obvious metabolic abnormalities such as hypertension, dyslipidemia, or diabetes. In a French longitudinal study of almost 3 million people with no prior heart issues, there was 1/3 increase in heart failure and atrial fibrillation in metabolically healthy obesity people. So there appeared to be no increase in the risk of heart attacks, ischemic stroke, or cardiovascular death, but the study's 5-year follow-up period may have been too short to show such effects. So there's a question mark about the term of metabolically healthy obesity as if it is a misnomer. Now I'll pass. This is my last part of the news about the ESD conference. I promise you to be back to this issue before I end my presentation, and this is my last news about obesity and recent news about obesity and diabetes remission. We all know the DIRECT study, which started in the year 2016, where obese, fairly recently diagnosed diabetic patients could achieve diabetes remission and live without diabetes medications for at least 1 year if they succeed to lose about 15 to 20% of their body weight. And in the year 2019, it was published that in those diabetes remission patients of the DIRECT study, C-peptide were normalized, denoting that the remission was not only due to improvement of insulin resistance secondary to the gross weight reduction, but because the function of the beta cells were also restored. And it was also found that the levels of fat inside the liver and the pancreas fell substantially, and that had resulted in improvement of insulin sensitivity in the liver and restoring the activity of the beta cells in the pancreas. That raised, this news raised the question, if non-obese patients could achieve the same effect if their weight is reduced enough to allow their liver and pancreas to get rid of the excess fat. That's the question which pushed the Diabetes UK to fund the study, Retune study, to answer the question if remission from type 2 diabetes is possible for people with lower body weight, not obese patients. So the early results from the Retune study were shown in a lecture given by Professor Roy Taylor from the Newcastle University in the ESD 2021. And these are the early results announced by Professor Taylor. So far, the research team has finished data collection for about half of the participants who had an average body mass index of less than 25, normal BMI people. And those on low calorie program lost weight and lost fat from their pancreas and liver. This is through the MRI managing or imaging of those patients. And around 2/3 of those patients are going into remission. Very good news for non-obese patients. So while these early results are exciting, we have to wait for the full results expected next year before we finally know if remission is possible for patients with type 2 diabetes and body mass index less than 27. So these preliminary results suggest that weight loss can benefit people with type 2 diabetes who appear to be of normal weight, they too have the chance to going into remission, and the final results of the RETUNE study will be available next year. Now for conclusions, Mr. Chairman, the virtual EASD conference 2021 has announced important breaking news regarding different aspects of the relationship between obesity and diabetes. Weight loss should be a primary goal in type 2 diabetes treatment. Obesity, especially of the young, is an important and challenging problem in type 1 diabetes. Metabolically healthy obesity may not be as benign as it was previously thought. The term may be a misnomer. Diabetes remission has been excellent news for obese diabetics. It looks that non-obese diabetics as well may have the chance to enjoy the same good news. Thank you.
Thank you very much, Professor Adil Said, for this nice and very interesting topic. I think there are many questions, Professor Zaman Sheikh.
Okay. First question to Dr. Mohammed Suleiman. Any side effect with teplizumab? Before I forget, I must thank Professor Jamal Bilkader for conducting this excellent conference, virtual conference. Okay, so question to Mohammed Suleiman. Any side effect with teplizumab in regards to delay in type 1 diabetes? And can this be repeated again?
Okay, thank you very much. So the study that looked at teplizumab in prevention of type 1 diabetes obviously looked at people who are at high risk, who had positive antibodies. It was given every 2 weeks. It was generally found to be a safe drug. No significant side effects were really seen. Obviously, if you want to go by the evidence, you have to give it to the people who satisfy the criteria in that study. So these are people who are high risk, family history, and positive antibodies. But it was generally a safe drug.
Thank you, Dr. Suleiman. Second question is again to you. Do we have convincing data that COVID-19 may have toxic effect on beta cells? And is there any proof or studies done? And if so, what are the cues which can lead to suspect that this patient diabetes due to damage of beta cells?
Okay, thanks. So obviously, COVID-19 is a relatively new condition, and we are still learning about it. But the early evidence that's available now shows, yes, there is some evidence that it can be toxic to the beta cells. I'm not aware specifically of type 1 diabetes. It may bring the diagnosis earlier than it was going to happen, but definitely the early studies show some toxic effects on the beta cells. I can't precisely answer the question about type 1 diabetes, but I think theoretically it is possible because it can make the progress of beta cell destruction quicker.
Okay, thank you. Now, mic over to Dr. Fatma Munif to conduct further question and answer sessions.
Yes, thank you, Professor Zaman. Thank you. There are some questions as for from Syria to Professor Mohammed Suleiman. Do you agree that adding SGLT2 and weekly GLP-1 to GRAD will give a better evaluation to best treatment of diabetes? And especially these two groups have cardiovascular and renal benefits, which will improve the prognosis of the treatment.
Yeah, that's an important point. As I mentioned earlier in the study, the GRADE study did include a GLP agonist, which is liraglutide, but it did not include an SGLT2 inhibitor, and they gave good reasons for that. The main reason was the first SGLT2 inhibitor was actually licensed after the study started, and there was quite a lot of interesting discussion after the great presentation on why they didn't use SGLT2 inhibitors. They even considered adding them when the study started, but they found it would be difficult and the numbers will have to increase and so on. So it was a pity that SGLT2 inhibitors were not included. We would have had good evidence, but they were not included. Obviously, now what we know now is much different from what we knew at the GRADE study when it started in 2013. We now know that the GLP agonist and SGLT2 inhibitor have a huge amount of evidence in cardiovascular prevention, renal prevention, heart failure, and so on. So yes, these drugs obviously are here to stay. They go beyond glycemic control, and they're going to be used more and more. So they definitely have evidence, and I'm sure in any future study there will be included both of them.
Thank you, Dr. Mohammed. Now, there is a question for you, Professor Adli Said. This question from Dr. Ahmed Abul Halawi. To what extent you see success in the management of obesity?
In type 2 and type 1 diabetes, or in type 2 diabetes, or in general?
In general, perhaps.
Well,
it's not.
It's not. Thank you very much indeed. Treatment of obesity for type 2, as it is clear from my presentation, it might be introduced as a primary objective of the treatment of type 2. I agree about that, actually, and this is very important. But we heard from Dr. Mohammed Sulaiman, I had something very interesting, actually. The semaglutide is doing a very good job. It's very clear. I mean, it's almost touching what's happened with the bariatric surgery or metabolic surgery. So now I think increasingly we have tools in our hands to treat obesity, and for type 2 diabetes. For type 1 diabetes, the problem is even more complicated, because treatment-intensive insulin therapy will lead to increased weight. So this is the issue. Obesity will help destruction of the beta cells, and treatment with insulin will increase weight. So there is a vicious circle over there here. And we do not know exactly what will be the effect of something like semaglutide. The liraglutide and semaglutide and all these factors are important, but they are still hindered by their cost. They are very expensive. I mean, for most of our countries, not particularly in Qatar, I am sure, but in most of the countries, the cost element will be a great obstacle regarding using. But I think with mass production and with more and more aware of the problem, GLP-1 would be one of the answers regarding that.
Last question from Professor Adil Sayed. Is there a place for sulfonylurea on the phenotypic classification you mentioned for new classification of diabetes? Is there any place of sulfonylurea in any of the group?
Yes, there is a place for sulfonylurea, of course. Number one, for those who cannot pay for the other classes of the drug, that sulfonylurea is one of the cheapest classes of drug, and this is very important for us. Any classification which will exclude sulfonylurea, we have to remember that sulfonylureas are quite cheap. That's number one. Number two, definitely that of the insulin deficiency. There is a place definitely for sulfonylurea. If the basic pathogenetic factor behind diabetes is insulin deficiency, then it is logic that giving something which can stimulate beta cells to secrete more insulin will be suitable. So yes, sulfonylureas are there. They have never lost their places. And I hope, and even when we compare sulfonylurea in the GRADE study mentioned by Dr. Mohammed Sulaiman, we saw that sulfonylurea did much better than the DPP-4 inhibitors, for example. So these are lessons which we have to be very aware of, because sometimes I feel that we are pushed and guided by the pharma industry, which, well, pharma industry is very important organizations, but they should not lead the movement of physicians towards treating patients. The treating patients should follow the evidence and the international organization which can look into this evidence and try to make the right scientific conclusions. Sulfonylureas are there, and they'll continue to be there, I think, and I hope that the saying that I have never used sulfonylureas for more than 20 years, that's rubbish. That should never be said in front of young physicians, at least. No, sulfonylureas are there and still being there for the coming period.
Okay, thank you very much. Before I give mic to Dr. Fatma Munif for finance, it's my pleasant duty to say thank you to Professor Muhammad Suleiman, Professor Adil Al-Sayyed for their excellent talks, and once again to Professor Jamal Bil Qadir for organizing this fantastic conference, and my colleague, Dr. Fatma Munif. Thank you very much, Dr. Fatma. Final comments.
Yes, thank you, Professor Sheikh Zaman. It's a pleasure for me to be here as a chairman. And I want to thank Professor Jamal Bil Qadir to give me this opportunity. I want to thank Dr. Muhammad Suleiman, Dr. Professor Adil Al-Sayyed, and to thank Dr. Muhammad Bil Aswad from Sfax from Tunisia, who gives me this opportunity to be here. And thank you for this Congress and for you, Professor Jamal Bil Qadir. Thank you.
Hi, my name is Tamer Al-Isa. I'm a consultant endocrinologist and head of division of Jabir Ahmed Hospital, and also clinical staff at Desman Diabetes Center in Kuwait. Thank you for Merck for their kind sponsorship for this symposium. I'm very delighted to be presenting this talk for you. So today we're talking about type 2 diabetes continuum, one journey, different approaches. So as we understand, the development of type 2 diabetes is a progressive in nature, meaning before even the onset of type 2 diabetes, there is the progressive changes of insulin resistance that carries away before even several years before the onset of diabetes. That's related also to the increase in the insulin secretion to meet the insulin resistance. With that also, the changes that happens with type 2 diabetes, they develop or they cause the decline in beta cell function. And with the onset of diabetes, a lot of patients with type 2 diabetes has already lost significant amount of their beta cell function. With these dysglycemic changes that happens even before the onset of diabetes, there is actually started to increase some of the risk related to the development of complication related to diabetes. So the increase in the postprandial glucose and also increase in the fasting glucose that starts even before the onset of diabetes puts the patients in more risk of developing macrovascular complications and even microvascular complications with much higher glucose values that goes on after the onset of type 2 diabetes. Both pre-diabetes and diabetes, both of them have an increased risk of developing macrovascular complications. So patients with impaired glucose tolerance, they have an increased risk of death from different causes like cardiovascular disease, about 34%, coronary heart disease, about 28%, and strokes, about 26%. Definitely with type 2 diabetes, that risk increases significantly, up to 55% with cardiovascular disease, coronary heart disease, 64%, and 74% with stroke. That's the increase in the in death from different causes related to the background condition. So as we said, the complications of pre-diabetes could definitely be similar or exactly similar to the complication that develops with diabetes. So patients at higher risk of developing cardiovascular disease, nearly 2 times the risk. And also they are at risk to develop macrovascular complication. Retinopathy is much less extent, but they do have that. Nephropathy is actually significantly. So pre-diabetic patients versus the control, 17% versus 10%. And also neuropathic symptoms, also their patients are increased risk to develop that. So pre-diabetes and diabetes are associated with macrovascular complications. Also, so the retinopathy, increase in the retinopathy in diabetic patients, about almost 60%. In patients with pre-diabetes or pre-diabetes and impaired impaired glucose tolerance subjects, they're also increased in the development of polyneuropathy, about 75%. Nephropathy also increases in patients with pre-diabetes up to 67%. So patients, in terms of guidelines, and this has been updated very recently with the standard of care in diabetes by American Diabetes Association in 2022 guidelines, is that the asymptomatic individuals to screen for type 2 diabetes. So patients who are overweight or obese should start screening for type 2 diabetes if they have a first-degree relatives with diabetes, high-risk ethnicities and race. They do have a history of cardiovascular disease, if they do have hypertension, low HDL or high triglycerides, women with PCOS, physical inactivity, and other conditions that show that there is an insulin resistance, like acanthosis nigricans, for example. Any patients with prediabetes, they need to be tested every year. Patients who are diagnosed with gestational diabetes have a lifelong testing procedures needs to be done at least every 3 years. And for all other patients, the guidelines, the current guidelines, the new ones, actually recommend starting screening at the age of 35 instead of age 45 in the previous guidelines. If the results are normal, they repeat the testing at minimum of 3 years interval. So prediabetes is specified as a fasting plasma glucose. If the level is below 5.6 millimoles, that's considered to be normal. If the level is between 5.6 and 76.9, that's considered impaired fasting glucose and prediabetes. In patients doing oral glucose tolerance tests, if they score levels of glucose between 7.8 and 11 millimoles, that's considered as prediabetes also. And also we can depend on doing HbA1c to screen for diabetes. So levels of HbA1c of 5.7% to 6.4%, that's also considered as prediabetes. So the risk of the level of A1C proportionally has a relationship to increased risk of developing type 2 diabetes. So patients with an A1C baseline of 5 to 5.5%, the relative risk developing diabetes compared to a baseline of 5% is twofold increase, where patients with the increase with the higher levels of A1C of 5.5 to 6%, they have 5 times risk developing diabetes compared to 5%. And if they reach between 6 and 6.5%, then the risk increased tremendously to up to 20% more chance of developing type 2 diabetes compared to a baseline A1C of 5%. The one most important trials that looked at prevention of progression of type 2 diabetes in pre-diabetic patients is the diabetes prevention trial and also the prevention program, diabetes prevention program outcome study. So the original diabetes prevention program have selected patients back in the 90s who have pre-diabetes and enrolled them in 3 arms, either lifestyle changes that included weight loss and exercise, metformin therapy, 850 milligrams twice daily, or placebo. These patients, on an average, they followed them for about 2.8 years. And then after this initial study, they evaluate them for additional 10 years and even up to 15 years to look at their outcomes. In the initial study of an average of follow-up of 2.8 years, patients on metformin compared to placebo, they had a 31% reduction in development of diabetes. That's the number of cases per 100 person years. While patients with lifestyle modifications, they even have a further reduction of progression into type 2 diabetes of up to 58% reduction compared to placebo. For a 10-year follow-up from the diabetes prevention trial, and patients with metformin therapy still had a significant reduction, 18% compared to placebo, while also with lifestyle modification did better in preventing progression of type 2 diabetes, 34% compared to placebo. That's up to even 15 years of follow-up in the diabetes outcome trials. Patients here are only divided into groups with lifestyle modifications and metformin. That's percentage of reduction of compared to versus placebo, 27% with lifestyle modification reduction, and even 18% here with metformin therapy. So either ways of reducing or preventing the development of type 2 diabetes, whether it's lifestyle or metformin, both of them had success rate in reducing the prevention for type 2 diabetes up to 15 years. And lifestyle did much better compared to metformin therapy. So the objective from the diabetes prevention program is that you want to have at least 7% weight reduction and at least about 150 minutes of physical activity. For about 24 weeks, you want to do that. That will help patients to improve their outcome and also reduce the risk of developing diabetes. The diet should involve low calorie, low fat with increasing fibers, and activity should include moderate intensity physical activity to improve this outcome. Changes in lifestyle modification is also important, but there is some issues with that. So lifestyle modification could be very hard to be constant on. So maintaining this could be difficult for patients. The compliance could be difficult also to patients, and the remaining lost weight over time. Some of them actually patients can regain that weight that has been lost. So a lot of these patients, unfortunately, with lifestyle modification not to be effective, pharmacotherapy can be considered who do not improve their outcome based on lifestyle modifications. So the pharmacological therapy that's interesting and to use to prevent the progression into type 2 diabetes is a therapy that reduces insulin resistance and improving beta cell function. So one of the therapies that's been used for a long time now to prevent type 2 diabetes is actually metformin. This is from the diabetes prevention trial, looking at subgroups of patients using metformin therapy and looking also at the risk reduction of developing type 2 diabetes. Patients who are obese with a BMI of more than 35, they had a 53% reduction in the progression of type 2 diabetes. Women with history of gestational diabetes, similarly, 50% reduction. Patients with high fasting glucose, almost similar, 48% reduction. And younger than the age of 60, also had a success rate of reducing the progression to type 2 diabetes about 30 to 44% reduction. Another trial, which is the Chinese prevention study, also have used kind of similar idea to what's been the diabetes prevention program, which is using metformin versus controls. In patients reducing metformin, when they are pre-diabetic, they reduce the progression for type 2 diabetes in the Chinese population about 65%. Also in the Indian diabetes prevention program, used similar idea to come up with a way of reducing the progression for type 2 diabetes. So lifestyle modification have reduced the progression for type 2 diabetes about almost 30%, with metformin about 26%, with lifestyle modification and metformin combined about 28%. So very similar results between the three arms of the intervention, whether it's metformin, lifestyle, or a combination. So these kind of ways of to improve the outcome and preventing development of type 2 diabetes are similar and good to improve the outcome. There was another overview of metformin in prediabetes to look at the outcome. So metformin has been shown significantly to reduce the risk of progression from prediabetes, principally with impaired glucose tolerance, to type 2 diabetes in several population. In the US with the diabetes prevention study, the Indian, which we already showed that, with the Chinese also data, which we already presented that. Also there are other trials in Pakistan and also in Canada showing similar reduction. These are the clinical trials with metformin effect in reducing diabetes risk. You can see the ranges of reduction with metformin. The diabetes prevention trial about 30%, down to some other studies reaching 66% up to even 88% reduction of type 2 diabetes. And the diabetes prevention program and the outcome study have combined to up to 15 years of therapy of data showing efficacy and safety of using metformin in pre-diabetic population. Metformin can have also additional benefits. It can help minimally reduce weight. So BMI in these patients have noticed to decline compared to placebo, about 5% reduction. Lipid improvement has been seen also with the use of metformin, like triglyceride reduction about 5%. LDL also similar reduction, and HDL improvement about almost 5%. And also positive benefit risk ratio, definitely it leans towards metformin having beneficial effect with very least in terms of side effects. Also, metformin is a very successful tool to treat patients with type 2 diabetes. So patients as an oral therapy, as a monotherapy, in patients and overall diabetic patients, overall type 2 cohort have made or helped patients, 7 out of 10 of them to be achieving the control. And even in patients with a baseline of A1C more than 9%, 6 out of 10 have achieved the control in these patients who are newly diagnosed type 2 diabetics. Also, metformin significantly can delay the need for further treatment intensification. This is comparing 3 different trials of 3 different monotherapies for type 2 diabetes, metformin, sulfonylurea, TZDs, and DPP-4s. Metformin has actually the least in terms of the need or delays the need for further intensification of therapy or adding another oral therapy, 24% compared to much higher ratios of patients, up to 36 to 39% of these patients on these kind of therapies, sulfonylurea, TZDs, and DPP-4 requiring additional therapy. Metformin efficacy as a monotherapy versus other antidiabetics. So you can see here that's the amount of A1C reduction metformin can achieve, somewhere around 1 to 2%. Sulfonylureas also can help to achieve that. TZD somewhere about 0.5 to 1.5%. Incretins generally and SGL2 somewhere about 0.5 to 1% reduction. Also, the dose of metformin, also the reduction in terms of fasting plasma glucose is proportional to the doses used. So metformin dose of about 500 milligrams can reduce the fasting plasma glucose of about 20 milligrams. That lowers even further to almost 30 with the 1,000 to 40 and even much higher up to 80 milligrams with the full dose of 2,000 milligrams daily. With HbA1c, similar reduction you will see with the increasing doses of metformin, about almost 0.7 or 0.8 reduction with the 500 milligrams, 1,000 somewhere about 1.3, 1.4% reduction of A1c, almost 1.7 to 1.8 reduction with 1.5 grams, and 2,000 milligrams can achieve somewhere around 2% reduction in A1c. Also, UKPDS have showed that metformin, when they are initially used, in patients who are overweight and newly diagnosed type 2 diabetic with a mean dose of about 2.5 grams of metformin. These patients have an endpoint to be successful when they're tight controlled with diabetes with the use of metformin, especially in the overweight population. At 20 years follow from the UKPDS in the intervention arm, there was any diabetes related endpoint was reduced by almost 30%. The diabetes-related deaths was reduced by 40%, and all-cause mortality 36%, and MI about 39%. And that's higher in some of these values, especially in any diabetes endpoint-related deaths and all-cause mortality, which much higher than the on the even further follow-up, about 30 years, showing similar reduction in terms of these effects, but lower than the beginner or the beginning intervention, the 20 years follow the initial data of the UKPDS. Also, with the metformin using extended release form versus the immediate release formulation, patients have benefited more from adherence because you can actually dose with metformin extended release. You can dose them as a single dose instead of twice dosing with immediate release. That gives better adherence. So patients have much more adherence to the use of therapy, 80% compared to 60%. Those patients who adhere to therapy more often, they had a better reduction of A1C. With every 10% increase in adherence, these patients have about 0.1% reduction in A1C. So these patients, more adherent, more reduction of A1C they have achieved. Also, with the metformin extended release compared to immediate release, these patients have reduced about 50% reduction in any GI adverse events, which is known for metformin to cause. And also diarrhea has declined significantly with extended form, about 75% reduction in diarrhea compared to immediate release. Metformin safety, there were no lactic acidosis or hypoglycemia cases during nearly about 18,000 patients years follow-up and some data from the diabetes prevention program. And hypoglycemia, non-serious adverse events were similar among metformin and placebo. And anemia adverse events with metformin and placebo and were mainly non-serious that was monitored. The main part of the metformin extended release, how they is formed, it has an inner polymer matrix and an outer polymer matrix. And in the outer form does not really contain the metformin. And actually that's what helps the metformin extended release to delay the absorption, while the inner polymer contains the metformin particles. Now, this kind of composition of the outer polymer matrix helps to delay the absorption and maintain the systemic exposure to metformin therapy. That's why it can be given as a single dose. Patients' adherence and patient preference to extended release metformin has actually been shown in surveys. So this is the patient preferences for extended release, almost 97%. This is the patient preference for immediate release, almost 3% only. So it's the dose is given as a once daily dose if the patient is using extended release. So a patient with prediabetes, preferred dose is somewhere about 1.5 grams. So that's 2 tablets of 750 milligrams. And also in diabetes, the maximum doses is 2,000 milligrams per day, given as 2 tablets of 1,000 milligrams given as a single dose. So patients, if they want to shift from a standard metformin or immediate release metformin to extended form, so if they're using a 2-dose metformin, so 500 twice a day, then they will be switched as a 1,000 at dinner time. Choosing dinner or lunch depends on the situation of the patient. In the trials in the diabetes prevention, they have used the dinner as a timing, but I'm sure it would be appropriate also to use it at a different meal time. If patients using 500 milligrams 3 times a day, that's a total of 1,500 milligrams. So it can be dosed as a 2 tablets of 750 extended release. And if the patient using 2 doses of 850, then also they can use 2 doses of 750. If they're using 2 doses of 1,000 milligrams, similarly, it would be shifted to doses of 1,000 milligrams, but given as a single dose or single time with the extended release form. So with that, I end my presentation and thank you so much for your attention.
Good evening, everybody. Assalamu alaikum wa rahmatullahi wa barakatuh. I hope you're all hearing me well. First, I would like to thank the organizers to involve me. Today, I'm Dr. Waid Al-Dhahi, President of Kuwait Diabetes Society, and with me, my colleague, Professor Inas Shaltut. Professor Inas.
Good evening.
Good evening, everybody. We have a session 7, diabetes and gut. We have just a little bit change in the order of the lectures. So we're going to start with diabetes and NAFLD by Luis Correa, Professor Luis Correa. I'm going to present him, then Dr. Inas Shaltut will take over after that. Yes. So Professor Correa is having a long-standing career in diabetes. He's president of the Ernesto Romeo Foundation in 2017. He was vice president of IDF International Diabetes Federation, 2008-2017 president of ADB Diabetes Portugal, director of National Diabetes Observatory. He's vice president of Ernesto Romeo Foundation in 2017. He worked as endocrinologist and diabetologist in Lisbon and in Portugal. He posted several high standard positions. He's also a vice president of Portugal's Society of Endocrinology and Diabetes and Metabolism between 2000 and 2003. He have lots of publications in the field of diabetes, and he chaired the ASD meeting in 2017. Professor Correa will talk to us about NAFLD and diabetes. Professor Correa.
Good afternoon to everybody. First of all, I want to say thank you for the invitation to be in this prestigious meeting. My name is Luis Gardet Correa. I am an endocrinologist and I am now president of the Ernesto Roma Foundation in Lisbon. I got to speak a little about NAFLD and diabetes. During the past century, dramatic modifications of lifestyle have radically changed health priorities in most areas of the world, owing to a growing incidence of non-communicable disease. NAFLD is one of the most important causes of liver disease worldwide and will probably emerge as the leading cause of end-stage liver disease in the coming decades. NAFLD is an umbrella for a range of liver conditions affecting people who drink little to no alcohol. The main characteristic of NAFLD is too much fat stored in liver cells associated with insulin resistance. Non-alcoholic steatohepatitis, NASH, a potential serious form of disease, is marked by liver inflammation, which may progress to scarring and irreversible damage, fibrosis. At its most severe, non-alcoholic steatohepatitis can progress to cirrhosis, carcinoma, and liver failure. NAFLD, it's a silent condition and certain escalations under estimated prevalence, extra burden for the development of metabolic conditions, asymptomatic until advanced stage, barriers to diagnosis, and direct markers do not provide a real prognosis. Causes of NAFLD. We don't know exactly why some people accumulate fat in the liver while others do not. NAFLD and NASH are both linked to the following: overweight or obesity, insulin resistance, high blood sugar, high levels of fats. Several studies show that NAFLD is an independent risk factor for incident, type 2 diabetes, metabolic syndrome, and cardiovascular disease. In persons with NAFLD, screening for diabetes is mandatory by fasting or radon, blood glucose, or A1C, and, if available, OGTT and in high-risk groups. In patients with type 2 diabetes, the presence of NAFLD should be locked for irrespective of liver enzymes levels, since type 2 diabetes are at high risk of disease progression. And what about the prevalence of NAFLD? The global prevalence of NAFLD is currently estimated in 24%. In the Middle East, we have 32%, South America, 31%, Asia, 27%, USA, 24%, Europe, 23%, Africa, 40%, and increase to up to 40 to 70% in people with type 2 diabetes. The main complication of liver disease in progressions to non-alcoholic steatohepatitis is cirrhosis, which is in late stage scarring, fibrosis in the liver. We see this picture starting with the half liver to a situation of cirrhosis. The step between NASH and NAFLD and NASH, it could be reversible, but the step between NASH and cirrhosis, it's irreversible. What is the fat in our body? We know that 75% is subcutaneous, 10-15% is visceral, and we have more or less 10-15% ectopic. Ectopic fat accumulates in the liver, heart, intestine, and skeletal muscle. From energy balance to ectopic fat, this is what happened in several places. In the muscle, more insulin resistance, less mitochondrial function. In the liver, more insulin secretion, more beta cell apoptosis, type 2 diabetes. In the heart, cardiac insulin resistance and less mitochondrial function. And in the liver, we have more insulin resistance and less insulin occurrence. So we have a lot of adipocyte dysfunction. NAFLD is associated with multiple conditions: type 2 diabetes, vascular disease, obstructive sleep apnea, CVD, cardiovascular disease, malignancy, and cerebrovascular. And about the NAFLD diagnosis criteria: presence of hepatic steatosis, no significant alcohol consumption, no competing etiologies. How we can detect and diagnose NAFLD? By ultrasound, CT, and MR, hydrogen 1 proton MRS, and fibroscan, fat liver index, steato test, or NAFLD liver fibrosis score, sero biomarkers, hepatic enzymes. Diagnosis by hepatic biopsy. Liver biopsy should be considered in patients with NAFLD who are in increased risk of having NASH or fibrosis. NASH detection and diagnosis. NASH has to be diagnosed by liver biopsy. showing steatosis, hepatocyte ballooning, and lobular inflammation. Fat liver index is an algorithm based in the waist circumference, body mass index, triglyceride, and GGT for the prediction of fat liver, and is easy to employ as each individual component must be a routine in clinical practice. We can find easily in the internet a calculator for fat liver index. We can find easily in the internet through an FLD fibros score. It's very easy to fill and very quickly we found a result. NAFLD interventions effectiveness. Lifestyle interventions is beneficial for patients with NAFLD, improving not only liver disease but also hyperglycemia, iatrogenic dyslipidemia, and blood pressure levels. Reduction in hepatic steatosis by lifestyle interventions is reported in the range of 5 to 50%. In case other risk factors are present, the intervention may also begin with an added pharmaceutical approach. Is it all about weight loss? Lifestyle intervention, being diet or exercise, seem to produce effects on NAFLD and NASH proportional to weight loss generated. Pharmacological intervention that produces similar effects seem likewise associated to weight loss. Also the same about gastric surgery. And what about nutritional recommendation? We have a lot of nutrition recommendations which are not very easy to follow. We have several off-label pharmacologic treatments like metformin, pioglitazone, liraglutide, vitamin E. We have drugs in phase 2 for NASH. We have in phase 3 trials for NASH 2. Finally, we have in investigation in phase 2 a new drug from Lilly, which is tirzepatide. Tirzepatide is a combining of between GIP and GLP-1. Tirzepatide shows significant reduction of A1C and weight in patients with type 2 diabetes, as well improvements in markers of NASH in patients with type 2 diabetes. Well, take-home message. The liver stores excessive nutrients as fat. NAFLD is a silent condition, generally undiagnosed and unaddressed, and clinicians tend to undervalue in its practice. Type 2 diabetes and NAFLD are reciprocal risk factors and constitute a vicious cycle. Hepatic fat accumulation changes not only liver metabolism but also impact other organs. Lifestyle change, hypocaloric diet and exercise target NAFLD proportional to weight loss, although effects can be seen easily. Thank you very much for your attention.
Thank you very much for your very short and good in-depth summary. If you have any questions, we have a 5-minute discussion at the end. Dr. Inas will present the second lecture. Professor Inas.
Thank you very much, Professor Walid. And now we have the presentation of Professor Dario Rahilic. He's going to speak about diabetes and microbiota. And Professor Dario Rahilic is an associate professor of internal medicine and diabetes. He's the director of Vorovak University Clinic for Diabetes Endocrinology and Metabolism, and he served as board member and secretary of International Diabetes Federation Europe and he's now the president of the Croatian Society of Diabetes and Metabolic Disorders. And let me introduce my colleague and very dear professor, Professor Abdelkhaliq Hamed. Professor Abdelkhaliq Hamed is a professor of a military academy. He's a consultant hepatologist and diabetologist. Professor Abdelhamed Khaliq, he's the president of Diabetes and Liver Group in the Egyptian Association for the Study of Diabetes and Gastrointestinal Disease, Secretary General of Arabic Association for the Study of Diabetes and Metabolism. He's a member of Egyptian Association of Endocrinology, Diabetes and Atherosclerosis, member of International Endocrine Society, member of Midscape Education International Project of Nuffield Nash for the MENA region. Professor Abdelkhaliq Hamed is going to talk about an important topic in our region, which is diabetes and liver cirrhosis. Professor Abdelkhaliq, please start.
Bismillah ar-Rahman ar-Rahim. Good afternoon, everybody. My subject today is diabetes associating liver cirrhosis. Agenda will include the pathogenesis of this diabetes, diagnosis, clinical impact, and treatment. Diabetes associating liver cirrhosis is called hepatogenous diabetes. Hepatogenous diabetes develops in cirrhotic individual as a consequence of liver dysfunction. In spite of evidence, the American Diabetes Association does not recognize hepatogenous diabetes. Nuffield, alcoholic cirrhosis, chronic hepatitis C, and hemochromatosis are more frequently associated with hepatogenous diabetes. Here is the pathogenesis. First important is the association of hepatogenous diabetes with HCV. Here it is caused by the virus itself, which will induce a very high insulin resistance. Diabetes starts very early, even in the stage of F0, and progress with the progression of the stage of fibrosis. Regarding diabetes association in compensated liver cirrhosis, it's about 80% had glucose metabolism disorder. Half of them were subclinical. 2-hour post-glucose load is a better screening test. The difference between highest and lowest blood glucose increased significantly with worsening of liver functional reserve. That is the main amplitude of glycemic excursion. Here is the proposed pathophysiology of hepatogenous diabetes in patients with cirrhosis. This is the cirrhotic liver, for example, in cases of HCV infection, metabolic syndrome, or Nuffield, leading to the peripheral insulin resistance. This cirrhotic liver will lead to reduced insulin clearance through portosystemic shunts or reduced hepatic mass, causing hyperinsulinemia. Those will lead to the glucose intolerance. Now, with the occurrence of decreased insulin secretion, will be frank diabetes. About the decreased insulin secretion, it's caused by increased advanced glycation end product and increase in the hypoxia inducible factor and decrease in beta-trophine. This will lead to beta cell dysfunction and decreased insulin secretion. Very important in the diagnosis is to distinguish features of hepatogenous diabetes from the type 2 diabetes occurring in subject with chronic liver disease. Hepatogenous diabetes onset is after cirrhosis. In type 2, it is before cirrhosis. Presentation of hepatogenous diabetes usually subclinical with normal fasting plasma glucose and glycated hemoglobin, but has abnormal response to oral glucose tolerance tests. Type 2 diabetes, over diabetes with increased fasting and glycated hemoglobin. Hypoglycemia is higher risk in hepatogenous diabetes. The effect of orthotopic liver transplantation may reversal or ameliorate of the diabetes in cases of hepatogenous diabetes. Regarding the traditional risk factor for diabetes, it's less frequently present in hepatogenous diabetes. Regarding complication of diabetes, that is the angiopathies, it's lower incidence. Regarding complication of liver disease and the mortality, it is higher in non-diabetic cirrhotic subjects. Another interesting differentiation of hepatogenous versus primary diabetes. Regarding symptoms, it's absent in hepatogenous diabetes, but in primary diabetes it can be very prominent. Regarding fasting, postprandial blood sugar is lower in post-hepatic hepatogenous diabetes, but equally higher in post-cirrhotic diabetes and the type 2 diabetes. Interestingly, is the fasting and postprandial insulin and C-peptide. It's higher in post-hepatic, slightly lower in post-cirrhotic, but it is low in cases of type 2 diabetes. The most significant is the islet cell antibodies, which is very high in cases of hepatogenous diabetes, reaching 82%. Both glutamic acid decarboxylase antibody and the islet cell antibody have important value in the diagnosis of hepatogenous diabetes and may serve as indexed in the laboratory test for diagnosing hepatogenous diabetes from type 2 diabetes. About the pros and the cons of the various glycemic markers, regarding fasting blood glucose, it's simple and inexpensive, but needs prolonged fasting. Oral glucose tolerance test is the gold standard for diagnosing diabetes mellitus, and it is the only way to formally diagnose impaired glucose tolerance. Again, the cons is the prolonged fasting. The important hemoglobin A1C can be used early in cirrhosis and in non-anemic patients. Of course, the pros is no fasting requirement, but the cons that affected by altered erythrocyte turnover, unable to capture glycemic variability, and affected by alcohol consumption. Regarding the glycated proteins, it is sensitive to rapid glycemic variation. Lastly, the frequent blood glucose monitoring. This is recommended, especially with the advanced liver disease. About the clinical impact. First, the impact on the diabetes complication or angiopathies. It was shown that it is the cardiovascular, cerebrovascular, and the retinopathic risk is low in hepatogenous diabetes. This is due to the protective effects of low serum level of lipids, lower level of serum lipoprotein little a, decreased coagulation function and thrombocytopenia in liver cirrhosis, also the low prevalence of hypertension with diabetes in patients with cirrhosis. In this interesting study, there was significant difference between diabetic with liver cirrhosis and those diabetes alone in the intermediate thickness of carotid artery. Regarding the effect on the liver, effect of diabetes on the liver. This is the other side. In normal liver, diabetes lead to increase of NAFLD by 2 to 5-fold, increased risk of HCV infection by 3.5-fold. In chronic liver disease, there will be faster progression of fibrosis and cirrhosis and increased overall and liver-related mortality. In end-stage liver disease, there is decreased overall survival by 40% in 5 years, increased risk of ascites, renal dysfunction, bacterial infection, and hepatic encephalopathy. Also increase the risk of HCC and HCC-related mortality. In liver transplantation, there is increased post-transplant mortality, post-operative complication, and acute rejection. Also increased risk of post-transplant metabolic syndrome and the new onset NAFLD after transplantation. Very interesting is that when assessment of prognosis of cirrhosis, what is the relation to glucose tolerance? It was shown in multivariate analysis have usually shown an independent negative effect of glucose intolerance or frank diabetes after a child BOE score or its component were taken into account. So diabetes has been studied as an independent prognostic factor so as to include it in the parameters of the child BOE and the MOD and the MELD scores. Finally, the treatment of diabetes associated chronic liver disease, the lifestyle is one of the most important, especially the weight loss in fatty liver disease. Regarding exercise, when it is appropriate, this exercise improves the peripheral insulin sensitivity and the muscle mass. Regarding smoking, is associated with steatosis and severe fibrosis in chronic hepatitis C. Interestingly, is the coffee consumption, which is shown in HCV patients to lower the rate of disease progression and more likely to have virological response to the old treatment, pegylated insulin, pegylated ribavirin. It increases the insulin sensitivity and inhibits the development of steatosis. In metabolic syndrome, coffee consumption leads to decrease of the weight, blood glucose, leptin, and the increase in adiponectin. What about the drugs used in relation to diabetes and hepatogenous diabetes in liver cirrhosis? Regarding metformin, is still first-line therapy if it is appropriate. It increases the insulin sensitivity and decrease insulin resistance mainly in the liver. It is very useful in our case as it decreases the risk of HCC and hepatic encephalopathy and may lead to longer survival. About the contraindication is the renal dysfunction. Thiazolidine increase insulin sensitivity, but it is avoided in child B and C. No available data about its significance in cases of liver cirrhosis, hepatogenous diabetes. Regarding NAFLD, as we just hear from our dear professor, the present status for the treatment is bioglitazone, waiting for the new drugs for NAFLD. Regarding secretagogue, sulfonylurea, and glinides, it increases the endogenous production of insulin, not useful in our case of hepatogenous diabetes. Of course, the most important cause is the hypoglycemia. Regarding incretins, the GLP-1 receptor analogs and DPP-4 inhibitor, it increases the insulin sensitivity. No available data in hepatogenous diabetes. Alpha-glucosidase inhibitor, interestingly, is its use in patients with hepatic encephalopathy. The insulin, as we know, is a substitutive treatment often necessary in our cases of hepatogenous diabetes, especially in child C and in the presence of renal disorder. The risk is hypoglycemia. The new category, the sodium glucose transporter inhibitor, ameliorate diabetes, but its role in hepatogenous diabetes is still controversial. We have a new drug used in Japan since June 2021, called emiglamine. This will have an interesting role in our hepatogenous diabetes. My last slide about the strategy for diagnosis and the treatment in type 2 diabetes with cirrhosis. If our patient has impaired glucose tolerance or normal glucose tolerance, we just do annual follow-up. If there is chronic diabetes, the step 1 is lifestyle modification, body weight reduction with prevention of sarcopenia. Step 2 is pharmacotherapy. If we have normal renal function, we can use metformin. If the patient has no sarcopenia, we can also use sodium glucose transporter inhibitor. With the presence of abnormal renal function, if the patient is without sarcopenia, we can use sodium glucose transporter inhibitor. If there is sarcopenia, we can use GLP-1 receptor agonists. When there is abnormal renal function or child C stage, insulin should be used. In child A, bioglitazone may be considered, and interestingly, in child B and C, consider continuing metformin. Ladies and gentlemen, my take-home message is that in patients with cirrhosis, diabetes may be either a consequence of liver disease, just statistical occurrence, or underlying type 2 diabetes. In patients with cirrhosis, fasting blood glucose may be normal despite diabetes. Oral glucose tolerance test allows diagnosing diabetes. Diabetes is a factor of poor survival and increase the risk of complication of cirrhosis. Active screening and the management of diabetes could be beneficial. The use of metformin seems safe and may have a beneficial effect on patients' outcome. And thank you very much.
Thank you very much, Professor Abdelkhaliq.
So
Dario
we have
is ready.
Professor Dario until he joins us. He's Associate Professor, MD, PhD, FAC, FRCB, Edinburgh, Specialist in Internal Medicine, Endocrinology, and Diabetology. He's the Director of the VUC Courthouse University Clinic for Diabetes, Endocrine Metabolism Disease, Mercury University Hospital, Zagreb, Croatia, and Associated Professor at Croatian Catholic University School of Medicine. He's board member of Secretary of IDF Europe in between 2015 to 17. He's also president of Croatian Society of Diabetes and Metabolism and Croatian Medical Association, chair of IDF Young Leaders in Diabetes Program. You have lots of publications in the field of diabetes. Professor will talk to us about diabetes and microbiota. Please put down your questions in the chat box.
Thank you very much, dear ladies and gentlemen. Thank you very much for your kind introduction. And I would like to express my gratitude to Professor Shaltut for her kind invitation, for being present here in Croatia. It's Christmas Eve right now, and it's my pleasure and it's my honor to be present right now in your conference. So thank you very much, Professor Shaltut, for your kind invitation, and express my gratitude to the organizing committee, and send my greetings to all friends in Egypt, in MENA region as well, from Croatia on behalf of Croatian Diabetes Society, and also on behalf of VUC Vrhovac University Hospital in Zagreb. Professor Shaltut is very frequently invited speaker in Croatia, and it's my pleasure that she always delivers her knowledge to Croatian physicians. And I hope that our collaboration will be even better in all MENA region, and we are open-minded for it. And thank you very much, Professor Shaltut, for that. And also my greetings goes to all friends from Egypt and MENA region. So I will briefly, it's not easy to speak about microbiota and diabetes within 20-25 minutes or 15 minutes. but I try to summarize the most important thing. And my overview will be the pathophysiology of macrobioma, glucose and disease development, and also effects of glucose-lowering drugs on macrobioma and macrobiome modification as a treatment option for diabetes. There are numerous microorganisms that can have influence on the pathophysiology of metabolic processes in our bodies. But also, we have to say that internal and external factors for influence macrobiota compositions. Usually, we think about dysbiosis, and dysbiosis is something which means it's disbalance in macrobiota contents, and it's linked to development of a variety of illness, but also it means diabetes and obesity as well. Can you imagine that 100 trillion microorganisms are present in our gut, and 500 to 1,000 different bacterial species are present in our gut. From that perspective, when we talk about type 2 and type 1 diabetes, we know that microbiome has important influence in pathogenesis of type 1 and type 2 diabetes. In type 1 diabetes, we know that the current hypothesis stands that prolonged and repetitive dysbiosis may lead to a loss of self-tolerance. On the other hand, the A municipula has been shown to delay onset of type 1 diabetes in diabetes-prone animals. From the perspective of type 2 diabetes, we have learned that type 2 diabetes is associated with compositional changes in intestinal microbiota, and we know that obese people with macrobiota have influence. Just a second. It seems that obese people have lower prevalence of bacteroides and higher prevalence of firmicutes in those kind of people. And from the other side, complicated versus uncomplicated type 2 diabetes in the study of Zhao and his collaborated showed that increased BMI, pre-diabetes, and also the diabetes can have completely different effects on the diabetes outcome. So we can ask ourselves which bacteria are good. Studies show investigated specific genera often report conflicting results. However, some of them said that we can say that some of them, the results are mainly consistent. So we can say from the position of our, as a physicians, as a clinicians, we can say that Ruminococcus and also Fusobacterium and Glaucia can say that we are very happy with them because it's pretty consistent in many different clinical trials which confirm that all those three macrobiota species have beneficial effect on type 2 diabetes, and also all others have approximately negative. So the main problem in type 1 and type 2 diabetes especially, that it is intestinal permeability, and we know that in permeability of intestine, it's important to have short chain fatty acids, bile acids, and also lipopolysaccharides. Type 2 diabetic patients have decreased levels of mucin degrading bacteria. Also in obese mice, the restoration of normal levels of a macinicola has reduced endotoxemia. So always we are talking about the low-grade inflammation. So we have low-grade inflammation, adipose tissue inflammation, and insulin resistance as the result of it. The same bacteria may constitute up to 5% of microbiome in healthy person, and its relative decrease is associated with increased body weight, type 1 and type 2 diabetes. On the other side, the same bacteria was associated in many clinical trials with a healthier metabolic status in obese humans with improved glucose homeostasis and also energy restriction. So on another side, we can say that decreased intestinal wall integrity will cause the toxin will cause that toxin easily enter. Will easily enter the bloodstream, will cause the endotoxemia, will cause inflammation and oxidative stress, and that will cause the low-grade inflammation, as I already mentioned, and at the end of the day, it will cause the insulin resistance. So low-grade inflammation is of huge importance, because low-grade inflammation due to increased circulatory lipopolysaccharides produced mainly by gram-negative bacteria that will cause the elevate low-grade lipopolysaccharides serum levels in CD14 receptor 4, which will cause the pro-inflammatory state. The pro-inflammatory state leads to phosphorylation of insulin receptor substrates. Also, deficiency of insulin signaling in muscles, adipose tissue, liver, and also hypothalamus, insulin resistance, and beta cell damage, which will cause to decrease insulin secretion overall. Well, it's not so easy when we talk about it, but I will just try to summarize in this that gram-negative bacillus will have direct effect on CD14 and will have indirect effect on many other cytokines like TNF-alpha, IL-6, IL-1, TNF gamma, which can cause the insulin resistance, but also bile acids and also dietary fibers together with short chain fatty acids can cause inflammation and also insulin resistance. So at the end of the day, we can say that several things are the most important. Short-chain fatty acids produced by intestinal fermentation of dietary fiber are directly utilized by or for energy for intestinal mucous cells. On the other side, short-chain fatty acids can decrease glycolysis and glycogenosis, increase glycogen synthesis, lower plasma fatty acids concentration, and decrease the appetite and increase the feel of satiety. On the other side, it seems that short-chain fatty acids can produce strains which can decrease in patients with type 2 diabetes. On the other side, bile acids. So we know that conservation of primary bile acids in the intestine is controlled primarily by several bacteria like Lactobacillus, Phytobacterium, Enterobacter, etc. On the other side, secondary acid-producing bacteria constitute to glucose homeostasis, triglycerides level, and drug metabolism. And we are asking ourselves, is there some treatment target? So supplementation of secondary bile acids in deficient animal models improved glucose homeostasis. On the other side, bile acids, it seems that they have beneficial effect on dyslipidemia treatment, but however, studies show improved glycemic regulation as well. What about the medication? Glucose medication and also macrobiota. Effects of glucose-lowering drugs on macrobiome. I will briefly mention metformin and liraglutide. So the oldest one. So metformin has biguanide and GLP-1 receptor agonist. We know that metformin have beneficial effect in macrobiome composition, both in animal and also in human models, but also increase relative rates of different macrobiome bacteria, Akkermann and also the ratio between Firmicutes and Bacteroides ratio. But also, it seems that metformin lowered the effect of B. fragilis in intestine, which means improved glucose tolerance. But it seems that metformin can modulate gut microbiome constituted to increase the short-chain fatty acids, metabolizing bacteria in treatment rats. So it's all in the animal models. Some of these studies were confirmed also in humans. On the other side, liraglutide, which is very famous model from GLP-1 receptor analog treatment, it seems that liraglutide could modulate the composition of gut microbiota. And as you can see on this slide, liraglutide can decrease the relative abundance of relevant phytotypes. You can see it here: Bacteroides, Proteobacteria, and Acinobacteria. We are all, as a physician, we are not good in pronunciation of all these bacteria, but we know that many bacteria are very important. And it seems that liraglutide can have beneficial effect on those macrobiota model. What about treatment options? So we can speak about prebiotics, probiotics, fecal transplant, and niacin. So prebiotics are food-based chemicals that can promote growth and activity of macrobiome, including all those beneficial macrobiota microorganisms. Probiotics, it means live macroorganisms that enhance or replenish gut flora. The third option is fetal transplant, the process of transmitting fecal bacteria of interest from a healthy donor into a recipient. And the fourth version is the niacin, which can restore B3 vitamin. Here you can see the difference between prebiotics and probiotics. So prebiotics are dietary fiber, soluble dietary fiber, inulin type fructans, and which can improve intestinal burden function. Also can improve lipid metabolism and enhance the short-chain fatty acid production, or it can modulate macrobiome composition and improve regulation and also decrease oxidative stress. On the other side, we can use probiotics, which are live microorganisms. Probiotics can have positive alteration of intestinal microbiota, can have beneficial effect and can improve intestinal integrity, decrease systemic liposaccharide levels, and also can decrease plasma glucose and decrease HbA1c. Some studies show that beneficial effect on inflammatory markers, TNF-alpha and resistin, due to decrease a level of low-grade inflammation according to low permeability of gut permeability. The third option is fecal microbiota transplant. So it's highly efficient in treating recurrent colitis caused by Clostridium difficile. And a study of Cotter collaborators studied patients with metabolic syndrome who received fecal microbiota from living donors, and those transplantation improved insulin sensitivity within 6 weeks, altered microbiota composition, and also have the beneficial effect, which was temporary, as the patient must undergo the repeated treatment to sustain the positive metabolic effect. So from that perspective, we can say that it's transient effect, and it's not the effect for a long life, but still it's promising for the future investigations. Niacin, it seems that a reduction in a considerable amount of bacteroides in the microbiome of obese human subjects associated with a low dietary niacin intake shown that microcapsules with a delayed release can target the region of ileal colon to deliver niacin to niacin macrobide to the microbiome. The beneficial effect of it means that targeted microbiome intervention by the lead decrease of nicotinic acid might represent a positive therapeutic option for prodiabetes or prediabetes and also type 2 diabetes in the future. In the future, we can say that the beneficial effect of all these interventions can have that the intestinal microbiome plays important role in diabetes development, but also in human glucose homeostasis. On the other side, it seems that sustained glucose lowering drug particularly exert their positive benefits via microbiome. In the future, changes in microbiome may represent a viable treatment option for type 2 diabetes. So, ladies and gentlemen, it's a very limited amount of time to speak about microbiome and its effect on type 2 diabetes, on pathophysiology, and also on the treatment of type 2 diabetes. But it seems that microbiome has important role and play important role in the development of type 2 diabetes, maybe even in type 1 diabetes, but we know much better in type 2 diabetes. So there is no doubt that microbiome has an important role in type 2 diabetes. On the other side, it seems that the microbiome could have the beneficial effect on the treatment of type 2 diabetes. So we have to be aware that microbiome is important, not just in as a mechanism or pathometabolic effect on the development of type 2 diabetes, but it seems that microbiome could have important role even in the treatment of type 2 diabetes. So as a clinicians, we have to be aware of it. So in this moment, we can argue what is the more important thing, but it seems that our nutritional habits and also our recommendation to our people with diabetes would have beneficial effect on microbiome. And beneficial effect on microbiome could have beneficial effect on glucose control. And also maybe even in the control of cardiovascular risk. So from that perspective, we have to think about from the beginning. The most important thing is to educate our patients, because educating our patients, we can even target not just microbiome, but also we can target many other important pathophysiological mechanisms which can develop diabetes. But maybe we can delay diabetes from pre-diabetes or normal glucose control, and for sure we can help to our people with diabetes to prevent complications of diabetes. And I'm quite sure that microbiome could play important role in that from that perspective. So, as a physicians, usually we are targeting only medication. We are targeting oral or injectable anti-hypoglycemic, but we have to think about non-pharmacological treatment, diet, and also physical activity, because a special diet could have beneficial effect on microbiome, and microbiome could be the answer for the future complications, and also could be the answer for delaying of complications, could be the answer for the better glucose control. So besides classic, traditional medication, we should think about non-pharmacological measures, and we have asked ourselves, what is the most important for us as a clinicians? It's to have good glucose regulation. Our goal is to achieve good glycemic control, good HbA1c level, but also good lipid level and also good blood pressure level. Our goal is to decrease the cardiovascular risk, and I'm quite sure that also targeting to the non-traditional or non-pharmacological measures, we can do it, and we have to ask ourselves as a clinicians, do we think really about their people with diabetes diet, physical activity? How many percentage of our time we spend with them to ask, do you really follow our dietary advices? Do you really have physical activity as we advise? And at the end of the day, we have to ask themselves and ourselves, what about their microbiome? Because it seems microbiome is very important, not just in pathophysiology of type 2 diabetes, maybe even in type 1 diabetes, but for sure, right now we know that it's very important for the glucose control. So let's do it together. Let's think about it. Let's share our knowledge with our people with diabetes, our patients. They have to know that microbiome is important. And maybe with changing of microbiome, we can improve their glucose control, and we can help them to help themselves to have good glycemic control, but also to achieve good glycemic control within many, many years and also to have good quality of life. Because at the end of the day, the most important thing is the quality of life. And I believe that, or at least I tried to emphasize the importance of microbiome nutrition in the life of people with diabetes. Ladies and gentlemen, thank you very much.
We have two questions. I think one for Professor Dario, and the other one may go to Professor Abdelkhalik, since Professor Louis is not joining live. And the first one to Professor Dario. Do you think that microbiota plays a major role in diabetes etiology or not? I think you replied, but you can repeat your answer.
We are, as a clinician, I know that we are, as a physicians, we are all very focused on the medicine or injectable anti-hyperglycemic. So usually we don't think about nutrition, about physical activity. I'm maybe more involved in nutrition because my wife is she's clinical dietitian, and Professor Shaldut, she knows her very well. So probably that's I'm maybe, as a physician, I'm not typical physician. So probably because of her, I'm more involved in nutrition, and even I'm talking about nutrition in medical faculty here in Zagreb. But still, I think that it's not just about medication. It's about nutrition and non-pharmacological measures, as I already mentioned. It's important to emphasize the importance of non-pharmacological measures. On the other side, I think that the microbiome, it's uninvestigated and underestimated the problem in diabetology. So in the future, I think we should think about microbiome and also about nutrition, and not just short chain fatty acids, but maybe prebiotics, probiotics. But that will be the way for the future. All of us, we do know that chromium is important in glucose control. But rarely you can see and you can hear that it's important to have good microbiome. So it's underestimated problem in diabetology, and I'm quite sure that the changing microbiome will, in the future, will be one of the very important part of the treatment of not just type 2, but also in type 1 diabetes.
Great answer. Yeah, well, I mean, I think that the second question will go to Dr. Abdelkhalik.
Yes,
what
it's
about
his specialty. Yes.
Yes. So what we can do with diagnosing NAFLD, should we use a score or FibroScan, Professor Abdelkhalik?
We start to diagnose steatosis simply by ultrasound. Our next step is to use the non-invasive fibrosis markers. If the result of the non-invasive fibrosis markers is on the low cutoff, there is no need to further investigate the patient, and it will be very enough to reduce weight and change lifestyle. But if the non-invasive fibrosis markers in the high cutoff level or cutoff level, we should use here FibroScan. FibroScan is very important in diagnosing the stage of fibrosis, and also by the CAP maneuver, we can detect the stage or the quantity of steatosis in this liver. Nowadays, the FibroScan with CAP can be, instead of the biopsy, and it is in this time biopsy will be very limited use in cases of NAFLD or the new name MAFLD.
Yes. I think also you can answer the other question, I think the last question here, which is the use of pioglitazone in people with NASH. How safe, when to use? Is it safe to use TZDs in people with fatty liver?
Thiazolidine pioglitazone is very safe in use in cases of non-alcoholic fatty liver disease, and we can use it to decrease steatosis in the liver, also decrease inflammation. I think also it's a very important point is at what level of transaminases we should not use pioglitazone. I think the threefold of the normal, but in cases of MAFLD, the enzymes are not usually increased very high. So pioglitazone is safe. It's used for the treatment of non-alcoholic fatty liver disease in the present time, waiting to the new drugs. And it can be used to decrease inflammation and steatosis in the liver.
Thank you. I'll leave the floor for Professor Rinas to summarize the session.
Sorry, thank you. I just want to comment, if I may. So,
yes, yes, go ahead. Quickly.
I do agree with Professor Hamad with his comment. I think it's important to target NAFLD, because NAFLD is underestimated problem in diabetes, and pioglitazone is the only way right now in Europe, especially, and in majority of on the world, we have only pioglitazone as the main treatment for NAFLD and also diabetes, but also GLP-1 receptor agonists shown the beneficial effect on the also lean study and many other clinical trials, but lean study specifically shown the beneficial effect of GLP-1 receptor agonist on restoration of NAFLD. And also it seems that even SGLT2 inhibitors could have beneficial effect on the non-alcoholic liver disease. So it seems that it's very promising that beside pioglitazone, which is from my perspective the best solution for the NAFLD in this moment, it seems that GLP-1 receptor agonist and also SGLT2 inhibitors could have very good perspective in the field of not just diabetes, but also in the treatment of NAFLD.
In this session, we had an important updated topic about diabetes and microbiota by Professor Dario Rahilik. And we had also two important topics related to each other about liver disease and diabetes, which is a common comorbidity in our MENA region. Professor Abdel Khale was talking about liver cirrhosis and diabetes, and Professor Louis Gardet had his presentation about NAFLD and diabetes. And like Professor Dario said, we have the new anti-diabetic medications. All of them may have a beneficial effect on liver disease associating diabetes. So let's hope for more discussion and more research in the future. Thank you very much for being with us, and we're going to complete the sessions for today. Thank you very much, Professor Dario, Professor Gardet, and Professor Abdel Khale, and my co-chairman, Professor Walid Dahi.
Thank you very much, dear Professor Shaltut, dear Inas. It's always a pleasure to be with you and to support your activities, because you are doing a great job in Egypt and in MENA region. So it's always a pleasure for me. Even this Christmas Eve in Croatia, we have Christmas Eve, and just because of you and our friends from Egypt and MENA region, I said, yes, I will do that. and sorry for technical issues, but it was my pleasure to participate in the great meeting, and I wish you a successful meeting, and also I wish you all the best in the new year, and I hope that we will collaborate in the future even more and better than we collaborated till now. And thank you very much once again, and I have to express my gratitude for your kind invitation.
Merry Christmas, Dario. Bye. Bye.
Thank you very much. Bye-bye.
Bismillah ar-Rahman ar-Rahim. I am Dr. Musbah Kamil, Egypt. I am the president of the Diabetes in Asia Study Group, and also I am the Secretary General of our Egypt Diabetes Association. It is my pleasure to accept this invitation for sharing this session with my dear friend, Dr. Mohammed Sandid, who is President-elect of the MENA region. And in this session, we have three eminent speakers about a very important topic, which is diabetes prevention. Since the long time ago, since diabetes came into the scene, many efforts were done to prevent this catastrophic chronic disease. And because prevention is the main gate that can relieve the much of distressed complication of diabetes, so this will be always a concern and hope for all who are caring for diabetes in our world, either high or middle or low income countries. But in this session, we will have a mix of these concerns. We will first have the international perspectives of diabetes prevention from one of the well-known scientists, Professor Peter Schwartz, will talking about this, and then we will have our dear colleague, Professor Asher Fouad, for the perspectives of MENA region. And lastly, we must face what our culture and what our society and what is the socio-economic burdens and the challenges we are facing in our countries by dear colleague, Professor Rashid Malik from Algeria. So we will start first by a recorded lecture from Peter Schwartz. Peter Schwartz is the head of the division of prevention care of diabetes in cardiology staff in Dresden since 2008. And in the last 10 years, Schwartz has led a number of European and international projects for diabetes prevention. One of the well-known of this is the IMAGE project, and we have the opportunity to share Peter Schwartz's this project since about 6 years in Egypt through the Upper Egypt Diabetes Association, and we have learned a lot about the prevention directors, and we hope that we will continue in the coming years also. And also Peter Schwartz is one of the well-known publishers. He has about more than 200 papers in well-reputed journals with high impact, and he leading about 5 steering committees for the projects in Europe and internationally. and always Peter coming to us, and he is always welcomed in our area, in the Middle East, in Syria, in Lebanon, in Egypt, and everywhere. But COVID now obliged us to listen to Peter Schwartz's recorded lecture, but he will be available with us for questions for the living stream. So please, Peter Schwartz, the floor is yours.
Dear Chairman, dear colleagues and friends, dear ladies and gentlemen, thank you very much for the invitation and the chance to speak to you today. I must say I really feel honored about the possibility to speak at this MENA meeting and to talk to you colleagues in Pakistan about the prevention of diabetes, especially the international perspective of diabetes prevention. We have learned so many things about diabetes prevention in the last 15 years, but the essence of what is important is we have to make diabetes prevention easy. We have to make it practical. We have to make it, or we have to enable prevention in our daily life, in our daily activities. Only if we achieve this, we will succeed. The current situation is a challenge, and this is led by this colleague here. The coronavirus is keeping us very busy, and it's actually has changed a lot of perspectives into medicine. And this is also important in relation to prevention of diabetes, because, for example, in our state where I'm living in Germany, we see that the number of people with diabetes has increased by about 19 to 25% due to the coronavirus. So now I'm not saying that the virus is making diabetes, but the government reaction, the reaction on the pandemic, on the outbreak, with the quarantine, with social isolation, social distancing, staying at home, lockdown situation, this has led to a situation where people often gain weight. It's about 6.2 kilograms here in Germany, and this has led to an increase of prevalence of diabetes, and as an add-on to the normal increase. And if we're honest, this also means we have an increasing and probably fast increasing number of people with risk factors for diabetes. And this is where we have the chance still to prevent the disease from developing, and we have to do. Here are 540 people from Facebook, from Dresden. All the red one will develop diabetes through their lifetime. And this is a disaster, we could say, because these people are young now, but we know they will develop diabetes. But there are also the green ones. And the green ones, they have a secrecy of diabetes prevention, because the green ones live in the same environment. They do the same things. They may have the same risk factors, but they never get diabetes. And we don't know why. They have something in them, or they do something, or they have a kind of protection, or they have a kind of lifestyle protecting them so that they, through their lifetime, not develop diabetes. Our difficulty is, if two people walk through the door, we don't know who will get the disease and who not. So we don't know the secret of the green ones in how they prevent diabetes. But if we would know, we would have the answer for diabetes prevention. And in the upcoming minutes, I would like to touch some facets of successful diabetes prevention, what we have learned in the last years. There is a lot of new information, but I would like to start with information what is very easy. And these are these two numbers. If people from the age of 22 would walk 10,000 steps every day, they would not develop diabetes. They would not develop metabolic syndrome. They would not develop depression. They would not develop dementia. So this is a very hopeful message. This is based on about 87 studies who have investigated this topic. And this is very hopeful, but it's actually getting better if you have a patient with diabetes. And this patient is only walking 1,000 steps more than he is normally walking. This lowers the postprandial blood sugar by 1.5 millimole. This is twice as much as 1,000 milligrams of metformin are doing. So this is good. If we are honest, this means successful diabetes prevention is not in our brain as diabetologists or in our prescription as diabetologists. It's in the muscle of our patient. And it's our obligation to activate these muscles, because then we are successful, and then we are also sustainably successful. And we are lazy, because this is a number of how many steps people are walking in the state where I am coming from. This may be totally different in Pakistan. It may be different in the MENA region. There will be regions where the people walk significantly more, but there are also regions where the people probably walk significantly less. So we are a lazy species if we are talking about the power of physical activity. And if I ask the other way around, how many hours per day we are inactive, the answer is disastrous, because 23 hours and 40 minutes, we are lazy. We are not active. We are inactive. We have a sedentary lifestyle. We need only, at least the people here in Germany, the 20 minutes to walk the 2,700 steps. This means we are not using the potential we have in our body for prevention of diabetes. If we would succeed. But to understand this success story, we have to understand the pathophysiology. And here you see glucose monitoring using CGM and FGM in a healthy individual. And you see this woman has an A1C from 5.2, so a kind of high normal. And she's always eating something. All the green arrows means she's eating. And the purple line is glucose. And we see nothing. This is what we have learned in the last years about CGM and FGM. Normal means flat glucose curve. And this is important in terms of evaluation of activities for diabetes prevention. So this is normal, but here you see her father. So it's also truly her father. And he's actually having a better A1C because he's not eating so many snacks, but he has a totally different glucose curve. There are fluctuations here and here. This is maybe breakfast, this is maybe lunch, then glucose is going down. There was no treatment, there was no physical activity. The difference between the two persons is, I jump one slide back, this woman is very insulin sensitive. So she needs about 1% of her insulin to regulate blood sugar, and her father is very insulin resistant. He needs about 80% of his insulin to regulate blood sugar. And even if the current situation is actually better than for the daughter, he needs maybe 2 or 3 more years and he will develop hyperglycemia and diabetes mellitus. And it may take another 10 to 15 years until we diagnose him. And this is a disaster. Here we have to act. Here we have to become better. But we also have to understand that this fluctuation of glucose, they drive morbidity and mortality of our patients. It's difficult to find them. We cannot do CGM and FGM for everyone, but this is a pathophysiology behind. So our goal would be that we cut high glucose values and that we cut low glucose values to normalize the amplitude of fluctuation of glucose. And this is also relevant for prevention, but also for diabetes management. So putting this together, if we see the progression to diabetes from someone with normal glucose tolerance, IGT, to diabetes, then there's glucose increasing, insulin starts much earlier. This is represented by the insulin resistance. Proinsulin is a very strong driver of insulin resistance, transmitted by free fatty acids secreted by the visceral fat, BPO, and represented by the visceral obesity, the driver of diabetes risk. But there is a new fat compartment, and this is the hepatic fat. And I always like to say the visceral fat is making us sick, the hepatic fat is killing us. Why I'm saying this? Because the visceral fat is secreting this free fatty acids over the period of progression of diabetes, as shown here. But there are more than 600 known other peptide hormones also secreted by the visceral fat. They act on the brain, they act on the muscle, they act on the heart, on the pancreas, on all our organs, and 98% of them increase the risk of chronic diseases and also diabetes. So more visceral fat means more of this hormone and more risk. Less visceral fat means less hormones and less risk. And the story is different for the hepatic fat. For example, we could compare, or let's say if you have a person who has about 100 grams of fat in the liver, this is less than I can put in my hand. He has a high risk of becoming a non-responder to physical activity and a non-responder to a change of dietary habit. We cannot fully explain why it is like this, but we see that with an increasing amount of hepatic fat, the response to preventive interaction is ceased. And this is a disaster, because imagine now you have people who change physical activity, they change dietary habit, but there's no effect. And if you're honest, we all know people like this, and this may be transmitted by the hepatic fat amount. So we have these two fat compartments, and we basically have to abolish both if we want to be successful. And the question, how can we get the visceral fat away? This is purely physical activity. As more physical active we are, as less visceral fat is accumulating, and we can abolish and reduce the visceral fat. But what can we do with the hepatic fat? And the only way to get the hepatic fat disappearing is fasting. If you don't eat anything for 2 weeks, so only drink water, we could call it water diet, you can make about 100 to 120 gram fat in the liver disappearing. And this is, in my eyes, the fastest gain of health we can organize for someone, for ourselves, for our patients, by fasting. So especially talking to you in the Muslim region, this is a chance. Yeah? I'm not speaking about the Ramadan style of fasting. I speak about water diet, and it means you have to drink about 5 to 6 liters of water per day, but don't eat anything. You have to run into a ketosis, and the ketosis uses the fat to build ketone bodies, and by this, the fat is reduced. And it's fascinating, if you adjust your lifestyle afterwards a little bit, this effect sustains for years, or can sustain for years. So in my eyes, this is the fastest gain of health and the fastest way to diabetes prevention. Here, normally diabetes starts. Here we diagnose diabetes. We come far too late. So we have to think about these activities I just have spoken. We have to act in this clinical paradigm where we can act on hepatic fat, where we can act on visceral fat to make diabetes preventing. I already touched this. The visceral fat is making us sick. Hepatic fat is making us getting diabetes and finally is killing us. Removing the visceral fat works by physical activity, 10,000 steps a day. Hepatic fat by fasting, not eating any calorie for 2 weeks. And here you see 2 examples. This is subcutaneous fat, and this may not look nice, but it's from an endocrine perspective not so relevant like this small amount of visceral fat in this case. So this is what we have to make disappearing. Here is the signal, the insulin signal transduction cascade. All the red substances are coming from the visceral fat or hepatic fat and block this process. And the interplay between visceral and hepatic fat is a common soil for all these diseases written down here. Also something like psoriasis and dementia, and the liver fat is responsible for non-response in this field. Prevention is effective, and we know this. You may have heard this already in other lectures. This is a summary about the prevention study. So always the idea, I take someone with an impaired glucose tolerance, I apply an intervention, and how many patients, or what is the relative risk reduction? And we see here, it's about 50% for lifestyle. It's about something around 20 to 30% for a drug intervention. And you see the real life last line, it's about 55 for lifestyle interventions and 28 for drug-related interventions. So clear plaidoyer from my side for lifestyle change, for diabetes prevention. It's a pleiotropic intervention with pleiotropic and common effects. And this is what is true prevention of diabetes. These are the 5 goals. Initially coming from the diabetes prevention study from Finland. And the interesting story from these 5 goals is, if you cannot adhere to any of this goal, 8 out of 100 people develop diabetes per year if they have an IGT. But if you adhere to all 5 goals, none is doing it. So this is, let's say, cool, because we have here a clear roadway how to prevent diabetes by lifestyle change. And this is what we should recommend our patients. So summing this up, we see the different studies for diabetes prevention, the diabetes prevention program in the US and diabetes prevention study. has achieved what is here with the red and the green arrow shown, and the Indian and the Chinese program have achieved a little bit broader patient clientele. But this is what is the pathophysiology behind prevention. But we have to understand also our patients or the people at risk. And if I would stay in front of you now, I would ask you how many of you like to drink a Coke, and then I would ask about a Diet Coke. And here you see 380,000 patient years on this slide. And it was analyzed, if you drink one soft drink per day for 1 year, what is it making with diabetes risk? And if you drink water, it does not make anything with diabetes risk. Normal soft drinks and orange juice is making 40% risk increase, like a Coke is doing, but the Diet Coke or Coke Zero is making 60%. How can this be? And this is, in my eyes, one of the major drivers currently for the diabetes pandemic. It is because of the artificial sweetener. Because many of the big companies now say, okay, we understand we should put less sugar into our drinks. But on the other hand, the people would like to taste sweet. So what are they doing? They put artificial sweetener. There are 38 different artificial sweetener available, and 36 are doing what I just want to tell you. They change the microbiome. So they change the bacteria in the gut. E. coli is not disappearing, but is somehow abolished. And there are 13 to 14 different germs moving into our gut. They help us also digesting, but they do something bad, and they produce fatty acids, and we accumulate them through the gut, accumulate them in the liver. And the disaster is this accumulation of the free fatty acids or the fatty acids coming from this bacteria in the gut, they make an accumulation of liver fat, and by this making us getting diabetes risk and progression to diabetes. So this is also a disaster, because if you drink soft drinks with no sugar and artificial sweetener, you do it because you want to adhere to a healthy habit, but it makes it actually worse by this mechanism through the liver fat. And here's a study showing this, that due to the change of gut microbiome and the production of these fatty acids, you become a non-responder to exercise. So this actually makes another add-on, that you're not only becoming, you change your microbiome, you get liver fat, but this is making you becoming the non-responder to physical activity, even if you are physically active. And this is something we have to add on. Here are two pictures of our colleagues. If they adhere to this lifestyle, it's not easy to change lifestyle, but this is what we have to do together with our patient. And this slide shows you who is deciding about lifestyle. If someone has cancer or infection, they follow us as physicians. If we talk about diabetes and obesity, we as physicians are relevant in the moment the patient is sitting in our office. But in the moment the patient is going home, the other patients, the peer group of the patient, is becoming relevant to the patient's lifestyle, and he's much more effective than we are as physicians. So we have to accept on the one side that we are not the decision maker for the lifestyle of the patient, that this is the family and the peer group of the patient, but we can initiate or act or motivate to a lifestyle. But this recommendation must as good that it improves quality of life for the patient, because the patient will only adhere to a change in lifestyle if we are able, or if he is able to recognize within 2 days an improvement of quality of life. So this is a challenge. This is a threshold we have to meet. This works. Behavior change works in stages: motivation, action, maintenance. Here's the evidence behind it. But here you have techniques written down you can use if you are talking to the patient, like motivational interviewing, reflective listening, change talk, to help the patient to move through the stages and to finally sustainably change lifestyle. There are standards in diabetes prevention. I had the chance to lead a large international initiative, the IMAGE project, and we have developed practice tools or a practice toolkit for diabetes prevention, which is today implemented in 87 states worldwide, and it's continuously getting updated. And we also have developed a training program for prevention managers where people who are interested in diabetes prevention can learn how to do it. In this toolkit, we try to give a positive message, not only for healthcare provider, also for politicians, because we need politics to build a frame around the diabetes prevention program, but we need us to live the diabetes prevention or to put life into the diabetes prevention program. And we ask easy questions and we give easy answers to these questions, like it is written down here. But we also think about how to budget, how to really act on it, how to plan a diabetes prevention program, and finally, how to succeed with the positive mission statement. The training for the prevention managers is like a standard curriculum, and it's also a little bit built out how they can develop their own diabetes prevention business successfully based on the scientific evidence and successfully planned to reach people and to help them to prevent diabetes from developing. And finally, you need programs, and here are examples from colleagues worldwide in different languages, culturally adjusted, different programs going along with the dosage of risk of the people. So as more risk they have, as more difficult the setting is they are in, you need a different program, different intervention content for them. But finally, we have to address the needs of the people who have a risk. Yeah? We have to address what they want. We have to go to them to motivate them. And this is a concept which was developed, a three-dimensional concept where you basically can put in every stereotype of person at risk based on the medical risk, the readiness to change behavior based on the model I just have shown you, but also very individual preferences of the person at risk. And if you say, okay, this three-dimensional program, we can position every person in it, but we also can position every content for diabetes prevention in the same three-dimensional room. And what does it mean? The content will match the preferences and the need of the person. And by this, we postulate that using this content, using this information or motivation strategy will be per se more successful than using it from a different stereotype. So we can call this risk assessment, and we can combine this with data we have on digital tools, for example. And like it is written here, many of us use smartphones, and many of the smartphones store data we could use for risk assessment, but we also can use for intervention. So what we could say, we call it competence toolbox. We do an assessment based on the three-dimensional view. We combine it with digital data. We call it risk assessment or stratification. And then we have 100 different intervention qualities or the intervention contents, and the assessment will tell us which of the content will be adaptable or effective for this person. And this will help us to personalize or individualize intervention. And finally, digitalization, I think, can be disruptive to our ways of providing diabetes prevention. And here you see how the different oral diabetes drugs are able to lower A1C. We see how lifestyle can lower A1C. And at the end, we see how digital interventions developed until 2010, until 14, until 18 can lower A1C. And look at this column. As younger they are, as better they are to lower A1C. Why can this be? It's not because digital tools become better. Of course, they become better. They become more clever. They become more intuitive. But at the end, it is because they influence lifestyle. And at the end, this column you see here is not a representation of digitalization. It's representation of the change of lifestyle of the person. And this, in my eyes, is the power of digitalization for diabetes prevention. We are in the pocket of our patient. If we are using the smartphone, we never have been so close to our patient. We should use this power for diabetes prevention. So I think this is one kind of future for diabetes prevention. We can also use digital training programs or schooling programs for people for diabetes prevention. We can train them using the smartphone. And here are two examples of apps we have developed in Germany using what we are using for diabetes prevention. We basically used scientific evidence and we applied it and let's say into a consumer product for diabetes prevention. And this is becoming a success story. We learn more and more. We learn also from the mistakes we are doing, but at the end, we are achieving a success story in diabetes prevention. Is this enough? Of course not. And there's one point I would like you not to forget, and this is walking 10,000 steps from the age of 22 will basically prevent any chronic disease. And walking 1,000 steps more as a diabetes patient is the same as powerful as 2 pills of metformin. But we would have to motivate ourselves and our patient to walk using the muscles. And pedometers, here you see all the old pedometers on the slide. Pedometers can be very powerful. If you use a pedometer and you look 3 times a day onto the step count, you walk 3,000 steps more at the end of the month than at the beginning of the month. Very cheap intervention, very effective. But here you see 31 diabetologists in Germany from our last diabetes meeting on the slide. Only 1 is using the stairs. All the others run to the escalator and stay there. The airport in Doha, the airport in Munich, the airport in Dammam in Saudi Arabia. So these are photos from diabetes meeting. These are we as example, as good example for our patient. This is maybe something we can start, a little change, which can be a very powerful way for diabetes prevention for our patients. 10,000 steps is what we should achieve. This is evidence-based, healthy lifestyle. Don't forget the 10,000. This is the number for diabetes prevention. And if we use all our knowledge, all our intuition, all our interest and passion, then I'm very sure that we will finally walk away from diabetes. Shukran. And with this, I thank you a lot for your attention and feel very honored to speak to you at this MENA Congress.
Thank you very much, Peter. And I think this was a very good lesson. We will come at the end of the session to these conclusions. But we will now proceed to our communities. Professor Asher Fouad is a professor and chairman of the research and biochemistry department at Pakai University, Medical University in Pakistan. He is also a consultant diabetologist and director of the research department in Pakai Institute in Pakistan also. And he had more than 50 research projects under his supervision and the pioneer of the diabetes registry of Pakistan, what is called the DROP project, and serving for Diabetes National Study Group, Diabetes Association of Pakistan, and he is a well-known active researcher and epidemiologist in our area, and he will talk about the perspectives in MENA region about diabetes prevention. And I think he will give us a good insight about the state of the prevention in our MENA region. Professor Asher Fouad, the floor is yours.
So very, very kind introduction by Kamil. Always very kind as elder brother, and Sandeed, and I can see Altum and Jamal, many other our colleagues. So it's very nice. It was our hope that we can join actually physically, but at least we are here to discuss some very important thing. This is the prevention of diabetes. I am really grateful for all the organizers who are inviting and who are arranging this talk, and especially this topic. And I want to congratulate the organizers for this for such a successful event. Now coming to my topic, after talking Peter, it's difficult and at the same time it's easy in a sense that he has explained it very well. and he's the I must say hats off to his efforts. He has dedicated full of his life on this topic, this prevention of diabetes. So you can expect heights from him, and he has delivered a tremendous lecture explaining the mechanism. So I will not go in the pathophysiology of diabetes and risk factors, and the only thing he's saying what is happening in the MENA region, I'll go for that. So this is my institution. I have no conflict of interest to declare. So look at this latest IDF picture. We are having Pakistan at the third place, and the leading MENA region country with 33 million people of diabetes. So it's very alarming, and Egypt is at 10th number. And further going on in the coming years, this situation is further worsening. Now, what's in the MENA region? So prevalence of type 2 diabetes, you can see it's very high, 18.1%. And equally important is the proportion of people that are undiagnosed, 37.6%. So it's very high. So people prevalence of diabetes is high, not in terms of percentage, but number of people with diabetes and number of people with undiagnosed diabetes, and people who are at the verge of diabetes. Look at this IGTs and IFGs. So making it very high number. So we at MENA region are facing, we used to say previously that we will face, but now actually we are facing this storm, and we must say this tsunami of diabetes in our region, and we must adapt preventive strategies based on these figures. These are the percentages of all the countries, and Pakistan, followed by Kuwait, Qatar, and many other countries are having more than 15% of prevalence in MENA region. So we have many common things that we need to adapt. And first, we have to identify the risk factors, what is reported in the literature. Basically, as a researcher, scientist, and clinician, we must first identify what are the risk factors for diabetes. Then we will go for the preventive strategies for each of them. So what is the need in the MENA region? Risk factor for diabetes. There are some non-modifiable risk factors that we cannot change. Our race and age is, our race and genetic factors are really fertile for the diabetes. But there are certain things you can see on the right side in the green bar. It's having, we are having obesity, unhealthy diet, and physical inactivity. These are the three areas that Peter has also highlighted we can focus in the MENA region. In the MENA region, these risk factors are very high. You can see this dyslipidemia, hypertension, and obesity, family history of diabetes. So these are the reported literature from the MENA region. We are having very high risk factors for diabetes. And the prevalence of metabolic syndrome, look at these figures. Every second person is having this metabolic syndrome. And you can very well imagine the magnitude of the future diabetic subjects with this metabolic syndrome. So the numbers are very high, and the risk factors are there. So the children, what is the situation in children? Right from the 8 to 10 years old children, they are obese and overweight. And the reason, as Peter said, that the poor intake of fruits and vegetables, 80% are not getting the standard serving of vegetables and fruits, and 40% are getting these aerated drinks. So you can imagine this 8 to 10 years old children from the Pakistan representative of MENA region, and the reason why these numbers are high. So this makes the clear picture, and you will be starting the prevention strategies from these children. And these children should be focused, and clearly the risk factors are highlighted as poor dietary habits. So high prevalence of obesity and associated risk factors in urban children in Pakistan highlights the immediate need to initiate the primary prevention programs for diabetes. And another data from Middle East and North Africa region, a comparative risk analysis of the MENA region found that the leading risk factors for cardiometabolic disease and mortality is from 48% to 72% in different countries. And look at these figures, we are very much inactive. While Peter is emphasizing we must be active, and we at MENA region are highly inactive. This is the main reason. Apart from obesity, we are getting genetic risk factors, but this is the inactivity. We are getting these high numbers. So this inactivity should be addressed in the programs for primary prevention. After the school age children, this is the study we did in Pakistan, and we were the part of some Asian and other countries, genomic and lifestyle predictors of fetal outcomes relevant to diabetes and obesity and their relevance to prevention strategies in South Asian people. Though this is the another window, another area for primary prevention, maternal health, maternal and child environment, intrauterine milieu, and low birth weight and high birth weight both are at risk for diabetes and non-communicable diseases. So we must be focusing the maternal health while she is pregnant, and intrauterine milieu if she is diabetic with gestational diabetes or the pre-existing diabetes. The condition for all these things must be controlled in order to have good programming of the fetus and in order to prevent them for future diabetes. The catch-up growth and other risk factors in low middle income countries when the child is with the birth of low birth weight and then given up to catch-up growth. This is another area of prevention for diabetes in countries like Pakistan. So we did this survey with with Professor Akhtar Hussain and his PhD student, Dr. Basid's students in Pakistan. Peter very rightly said that it's possible. The prevention is possible. We can reduce the risk of diabetes by 70 to 76%. Lifestyle intervention is at the top. Metformin, no doubt, is in the use, but lifestyle is superior to reduce the type 2 diabetes, and we can very well say this lifestyle modification. No doubt there are responders, but as MENA region genetics with my PhD in the obesity genes, we are responding to lifestyle activities more as compared to other things, but we must be adhering the good diet pattern and good lifestyle, the healthy lifestyle, the active lifestyle, I must say the highly active lifestyle. This is the only way the MENA region can adapt the preventive strategies. Pakistan have started the Pakistan Diabetes Prevention Program at the national and ministry level. One of the province has started and the next province is about to start. We are about to share this with our colleagues, the guidelines committee. We have made the MENA region guidelines. In the next edition, we will be sharing it in order that other countries can adapt these programs based on the evidence we have sorted out in Pakistan and for this region. This is the MENA region guidelines. I am honored to have. I am honored to be the one of the author, along with the kind guidance with Professor Jamal, Professor Abdul Basid, and guidelines committee, the full guidelines committee, who have said that to identify the high-risk individuals. For the MENA region, there is a rapid score in this regard, which may be used for identify the high-risk individuals. Once you have identified the high-risk individuals, you may be going for them, because for biochemistry, it's very difficult to apply on the millions of people to check blood glucose. First, you can use this non-invasive test, which will tell you the risk of diabetes. Is based on these three questions: age, waist circumference, gender specific, and family history of diabetes. If the total score is 4 or more, this is validated and revalidated in the recent National Diabetes Survey of Pakistan, that it's proven that it's identifying the people at risk with more sensitivity and specificity that are statistically acceptable. So just 30 seconds and you can know your risk of developing diabetes. It has been accepted as the MENA region representative in the guidelines for identification of people with a high risk. And these are the strategies we have adopted in Pakistan. As Peter has said, exercise, the on top, reduce weight, eat fresh, stay hydrated, manage stress, and there are further some other things, and that can be culturally adapted. As our next speaker will be telling us, the MENA region is a very vast region, and we have some cultural specific things that can be adapted in this list. IDF is very supportive for preventive strategies. In the recent year, IDF has supported many projects, and as the data has suggested, lifestyle interventions are effective and to halt the progression of diabetes in those at high risk when implementing real life strategies in the low resource countries. So even the low resource countries can adapt these strategies, and IDF will continue to promote. This has been very kindly supported by IDF and its hierarchy. So it's going on, and we must adapt these strategies. This is a review. This is a conclusion from the review article latest published in 2021 in the Diabetes Metabolic Syndrome. To decrease the burden of diabetes, preventive strategies with proper cultural, in context with culture, are needed, and evaluation of current policies and identifying stakeholders. So as Peter, again, I would refer, it's not only the physicians, it must be the patients, stakeholders, and policymakers, decision makers, all should be at board to adapt this prevention program, and it can provide local and global insight to evidence informed decision, future policy reforms to enhance the effectiveness of the programs. So I must thank the hierarchy and leadership of current and the future with Professor Andrew Bolton, current president, Professor Akhtar Hussain, Professor Jamal as IDF MENA chair, and Professor Sindid as IDF president-elect for the MENA region. Peter, we are following your footsteps and we are doing walks, and these are the glimpses of our region. We have World Diabetes Day activities, walks, it's going on. It's Egypt and going to Tunisia, Bahrain, and all other countries are following. Lebanon, Pakistan, Afghanistan, Iran, Iraq, Jordan, Morocco. So we are having World Diabetes Day activities, Qatar and Saudi Arabia, Sudan, Syria. So all these activities are going on mainly as the World Diabetes Day awareness, education, and walk. We promote healthy lifestyle in our region. So we must unite hands to prevent this condition, and we must promote the inactive. We must promote the active lifestyle, and we must adapt the healthy eating and avoid obesity consequently. With this, I would like to thank the organizers and my panelists to allow me to discuss on this topic. And it's my pleasure to be with you on this talk and on this occasion. Thank you very much.
Thank you very much, Charles. This is a very illustrative talk. And now I'll deliver the turn to my co-chair, Dr. Mohammed Sandid, the president-elect of MENA region, to introduce the third speaker. And after this, we will have our questions and answers. Dr. Sandid,
yes, thank you, my friend, Professor Musbah. And thank you very much, Professor Ashir and Professor Peter, for this very, very nice lecture, information, and clear presentation. Diabetes form, as you know, a huge and rapidly growing global health burden in terms of morbidity and mortality. The burden is not confined to health, it extends to economic aspect. So diabetes prevention has also been a humanity happy dream. So now I will introduce, I am pleased to introduce our friend, Professor Rashid Malik. He is the head of the Department of Internal Medicine at Sétif University in Algeria. He's a very, very active member in the MENA IDF region. We'll talk now about prevention of diabetes, the socio-cultural challenges.
Thank you, dear friend. Thank you, Mr. Chairman, Mr. Sandid, Mohammed Belkhadir, and everybody who organized this very, very good meeting. My topic, it's a very pleasure and honor for me to give you this topic about prevention of diabetes and especially the social cultural challenges in our region. Type 2 diabetes is affecting emerging population in many countries around the world at an alarming rate. Understanding the complex biological element that influences disease development and progression in high-risk population is extremely important, but often insufficient to implement effective prevention and treatment plans. A variety of key factors, including socio-cultural factors, need to be identified for a better understanding of the socio-cultural issue. Look at this slide. It's very, very interesting. The first presentation by Peter speak about the DPP study. Look at the reduction or of the risk of reduction from lifestyle. It will be 78% by lifestyle, but 10 years in DPPOs, they become only 34%. And with metformin, from 31%, you have now 10 years after only 18% of reduction of risk of diabetes. And you still have a progression and increasing with the prevalence of diabetes, with the projection of IDF regarding the new IDF Diabetes Atlas. And we are especially interesting for this projection of IDF because in our region, in the MENA region, you have the increased projection for 87% in 2045. And the issue concerns the lack of prevention program, reduced financial resources, and Peter speaks about microbiota. And I think the epigenetics and the large demographic changement in our population may be a veritable problem. The epidemiologic and demographic transition is very, very important, like chronic non-transmissible disease such as diabetes and obesity. We have an increase in life expectancy, we have an increasing cost of healthcare, and we have a change of lifestyle not very favorable for our population. The nutrition transition model, it's another problem. Initially, this nutrition transition was limited to developing countries, then to migrants, and now is to be applied today to modernity, and the obesity is a consequence of these models. Many factors are interesting our countries. We have, firstly, a high prevalence of diabetes and future progression of type 2 diabetes and obesity. We have, secondly, early onset of type 2 diabetes. We have lack of health care facilities in some countries. Expenditure on care is not adapted to needs. We have rudimentary primary prevention policy, problem of beliefs related to social cultural identity, leading to obstacles in the treatment, sometimes the use of alternative medicine like plants, and absence of insufficient reimbursement of certain drugs. What are the action plans? We haven't many action plans, and we haven't many barriers. And a lot of barriers is the current reward system strongly encourages biological preferred behavior and bad behavior. The second one is the rewards of desired behaviors are mostly time discontinued, not immediate. And the historical perception of obesity is that it is a personal issue. It's a mindset. Another problem is the obesity in women. The obesity in women is a very problem and very stigmatization for population. Obesity is a value, or it is a social problem, social cultural, it is modesty, or it is an aesthetic problem, because a lot of obese consider that this is not illness, but this is a value for them. And the second problem for women is the women's sports against the current. The third problem is the food fast. The food industry practice a deceptive strategy. In festival, they are marketing and advertising product that increase food intake and energy consumption, like snacking products, increasing portion cereal. And after the McDonaldization and the hamburger, we have now another foods with a high quality of fat and with a large size of portion, which is very, very, very a problem with our population. The second point for the food industry is supporting intervention action in human nutrition and the dissemination of nutritional advice by public authorities. And finally, to absolve themselves of their responsibilities, they emphasize the individual responsibilities of consumers. Is that, or is there a national prevention program in our country? The response is no. The influence of cultural difference in diabetes prevention are generally underestimated. The cultural factors are always critical to the prevention of diabetes by influencing health behaviors. Furthermore, we have to emphasize the specific knowledge of communities, cultures, and history is crucial to the cross-cultural clinical encounter. And despite a growing body of research on the cultural competence of the physician and other healthcare providers, we can conclude that the conception of cultural competence versus diabetes prevention is still poorly understood. Look at this study of this trial. This is a critical review of national diabetes prevention and control program in 12 countries in the Middle East, and maybe Tunisia take part of this study. And the conclusion of this study is to decrease the burden of diabetes preventive strategies acceptable by the local socio-cultural context are needed. Besides its strengthening referral system, the government should allocate more funds to the program and more importance to the educational programs for the public. This is the prevalence of diabetes or type 2 diabetes in North Africa from Algeria, Egypt, Libya, Morocco, and Tunisia. You look at this number, you have between 7 and between 10% of prevalence. But in 2017, we have 3 children in Algeria, Tunisia, and Morocco with with stepwise WHO, and we have a big prevalence of diabetes, but this is not yet published. And this prevalence of diabetes, it's very, very high and very, very problem and issue in the next years. The other problem of social or traditional population is the when you organize a marathon for diabetes or for population at risk, you have only young people who consider this marathon interesting, and the adults is few adults to participate to this type of organization of our sport. And you have to find something like Peter said, walking, simplify the lifestyle for population and for diabetes. And walking, it's the most thing we can do in our region, in Morocco, Algeria, Tunisia, and other countries of North Africa. Another point is the practitioner. The practitioner have socio-cultural, have beliefs, have religion, and it is very, very important to be convinced, to convince others, and of course, population and diabetes. You have to regulate the strategy of food industry, an example for reserving parking space for cars with image for Fanta and XXL and a drink with sugars. The regulation for industries is the fraud of light products, and we know now that the light products, it's not conveyed for population, and more laws to increase the tax on sugar drinks. The action plans must be intersectoral. I give you an example of the integration of urban planners in the prevention plan, like sports activities, grounds, walking, and cycling. And it is very, very important that diabetes prevention should not be dissociated from obesity prevention. It is imperative to identify and understand our patient's unique biological, psychological, social, and cultural characteristics. If successful, we will be able to design comprehensive diabetes prevention and treatment programs in a collaborative and effective manner. In summary, ladies and gentlemen, the prevention of diabetes and obesity are linked and require a well-thought out action plan taking into account socio-cultural and access to care disparities, false beliefs. A multi-sectoral action is more than necessary. It is important to insist on simple prevention action involving necessarily a healthy lifestyle, and without prevention, we are facing major economic problems related to the heavy burden of diabetes and its complication. Thank you for your attention.
Okay, thank you, Professor Malik, for excellent talk. We listened to 3 important lectures. Various aspects of prevention are presented. To give the time for the question, let us take the floor for the question.
Yes, we have 2 questions. First, from our colleagues, Mohammed Tom, about the integration of the prevention programs in the NCD's plans. How can it be? I think Peter is not around, and I think Asher will be our responder.
Okay, so it was very nice talk by Professor Richard Malik, and he has very rightly said that it is the integrated approach. So obesity and other NCDs, which are the root cause, so it is not separated from the diabetes prevention. So all these risk factors are having common soil hypothesis. So we must address all the risk factors for NCDs, and accordingly, automatically, the diabetes prevention will also be there. And it's very important. I know Pakistan, the NCD program is not complete without diabetes prevention program. And we have shared from the platform of Diabetes in Asia study group. We have some examples from MENA region as well. So it's a combined program for all NCDs, it would be.
Okay, the second question also, Ashraf, came about the guidelines for prevention programs. Can be changed by the occurrence of pandemics like COVID-19 or so.
Yeah, it's really a relevant one. We have this pandemic, and this pandemic has forced us to be at home, and increased weight gain and some increased unhealthy diet is also there during this time. And those who suffered from COVID, who were hospitalized, were also treated with the steroid, leading to more and more exposure to this diabetes. So yes, but the data is now in evolving phase, and the guidelines will be revised in the next year for MENA region. We are taking this data for MENA region. Yes, definitely they will be changed. They will be affected, I must say first, and it will be more difficult for us to adapt these things and to reduce further this risk. And we can have this if this pandemic is now slowing down, hopefully it will be coming down, then the guidelines and the data will be accordingly adjusted.
Okay, the last question for you, and then we have question for Malik after. The question for you is that you elegantly showed that childhood obesity is the root of the problem of increasing prevalence and spread of diabetes. So when we are the issue of prevention, how can we combat this in the school age and the teen age?
The question is from my side?
Yes.
Okay.
About the school obesity, yes.
Yes. Okay. So this is very, very important thing. The school age, as Professor Rashid mentioned, the behavioral modification, and this is the right age which can be targeted. First, the intrauterine environment and their adjustment, then low birth weight and high birth weight, their proper management. And now this school going children, this behavioral modification and this good lifestyle and healthy eating habits changed by the whole environment, not only by that particular children only or the obesity only. So this will be from the top. The legislation will be there, policy making will be there, as we have said, this NCD and all these programs, National Action Plan will be there. As Professor Rashid rightly said, that increased taxes to the sugary drink will be there to avoid these sugary drinks from the area. We have one province in which we have restriction of all these unhealthy diets from the educational institution for a certain kilometer area. They cannot get these unhealthy diets. So these are the strategies. And further on, this will be the sensitization, continuous education. And this is the media. This is the time of media where we can have all these. We have Pakistan, this mobile ringtone, whenever you dial someone, this is there is prevention strategies for corona going on. We have offered ministry the same things for diabetes prevention, to avoid obesity, to avoid unhealthy lifestyle, and to promote right from the children. So it would be the whole environment that should be changed and then adjusted.
Okay, Professor Ashir, can I ask you?
Yes, yes, please. Yes, Mohammed.
Yes, or Professor Malik. Do you have any practical plan about type 1 prevention?
I think no. In the recommendation of IDA, of a lot of program of all societies, international society, this is the type 1 diabetes. It's not they not need a prevention program, but only if we have in the same family some children who have type 1 diabetes. We have to do some biological like HLA,
some genetic studies, yes.
Because antibodies, and but in the type 2 diabetes in children with type 2 diabetes, we have to screening type 2 diabetes from 10 years and for all obese children with obesity. But for type 1, I think it's so difficult, and all the studies who have tried immunosuppressive therapeutic or others, they haven't a long survey of for diabetes. There are only 6 months or less.
Thank you so much.
Okay, you have any comment, Rashid, about the story of the tax for sugary drinks and the role of parliaments and all over our areas can be involved as stakeholders for limiting the soft drinks and so sugary drinks?
Yes. I think many countries have this stipulation of with their countries, with their authorities, reduce the sugar in their drink and have a tax for drink sugar. In our countries, we have two problems. You have not control of industry. They can add sugar with coffee, they can add sugar with soft drink, and they can the light product of drink. It's very contain very important of aspartame, of fructose, and they are very dangerous for the weight, for the body weight, and for the BMI for the people. And until now, we haven't a program for control from authorities to drink soft and drink light.
Oh, thank you. So we will come to the end of this session too, and a very important session about the prevention of diabetes. This is a whole story. If we are going to improve the quality of life, to decrease the cardiovascular morbidity and mortality, and to even solving the issue of the economic burden on our societies, Peter illustrates the story in lifestyle, and he was elegantly showing us that 10,000 steps daily at the age of 22 can go with a very effective manner to stop diabetes all around. And also the early intervention and individualization is very important. So even when we are talking about the implementation of this lifestyle, we must take the preferences, the behavior, the cultural aspect, which have been clarified very well with Rashid. Rashid actually addressed the culture. We have culture of feasts and fasts and festivals, and we are all over our countries in the MENA region. We have diverse habits concentrating on eating and how to prepare the very mortal dishes, going us paving the road to diabetes and obesity. And also we must involve the stakeholders. We must change our mindfulness of healthcare systems to give these challenges. And we must educate not only the people, but also the healthcare providers, because many of the healthcare providers underestimate the issue of prevention, the issue of education. And Asher also said that the unity and while going together, even in our ceremonies for World Diabetes Days or the other congresses or our activities, we must work hard. We must concentrate on the prevention issue. We must take all the people that we can on our side to prevent diabetes from progression and to alleviate the socio-economic burden on our societies. My last word to Muhammad Sandid, if you comment.
Okay, thank you. Most important discovery which has not received the attention it deserves. I think we need to focus on implementation for prevention. Finally, I would like to thank again the three speakers for this very, very important lecture. Now we can move to the final session. Thank you.
Thank you.
Thank you.
Thank
you, Rashid. Thank you, Asher.
Bye-bye.
Happy to be with you and very, very good presentations. Thank you.
Bismillah ar-Rahman ar-Rahim. I'm very delighted to sharing this the last sessions. I know everyone is tired, for I think more than 5 hours. So I'm pleased to sharing with my friend Dr. Amir from Iran these sessions, and I will start to introduce the first speaker. He's Dr. Mohammed Al-Tom. He's from Sudan. I just look for his CV. It's have a long one, so I will try to highlight the very important point of his CV. So he's Professor Mohammed Al-Tom is graduated from the University of Khartoum, and he studied his clinical practice in Sudan and Britain. He received his doctorate degree and specialization training in medicine and endocrinology from Uppsala University in Sweden. And also he worked as a consultant physician endocrinologist in Omdurman Teaching Hospital. And currently he's a professor of medicine in Ahfad University in Sudan. He published about more than 42 papers actually, and before he was the ambassador of Sudan in Norway, Denmark, and Finland, and Iceland. He is the founder of Health Diplomacy at MFA, and he's the president of Health Diplomacy Association People Friendship Council. Please join me to welcome Professor Al-Tom.
Thank you very much for the introduction. The world is marking insulin centenary, so it is timely appropriate to address the challenging issue of its availability in the MENA region, starting with availability, with affordability, as affordability is connected with availability. Item is not affordable. If it is not affordable, then it means indirectly it is not available. And availability is associated with cost and readiness to pay. If people are forced to pay, then this might lead to poverty. We take this example of insulin. Insulin is an expensive drug which could be counted as the largest amount of out-of-pocket expenditure in low-income countries. In low-income countries, most of the out-of-pocket expenditure is not less than 70%. That is, when we compare it with high-income countries, the expenditure per individual is more than 5,000. While it is in low-income country, it is 138, which is too low to give good quality of care. And that means people are not affording an insulin, and they are forced to pay it. And all they might be rationing it. Rationing of insulin is not only in the low-income country, but in all other countries, including the high-income countries. Like, for instance, there is a hearing in the Congress recently by Congresswoman Diana Digatti, she mentioned that 1 in 4 people with diabetes are rationing insulin. So that means this is a common disease, both a common deficiency in high and low income countries. We can take this as well also to discuss the expenditure of diabetes global wise. We can see most of the African and Asian countries are spending less than $250. Our region, the MENA region, is expending less than 1,000, with the exception of oil-rich countries and Iraq and Iran. So from this, we can see that insulin would be most likely an important issue on the diabetes cost and diabetes expenditure. It is regarding the life cycle of insulin, there is a lot of barriers and challenges from its inception or production up to when it comes to the patient. There is in the innovation, there is true lack of innovation to change the management of diabetes. So that needs to be addressed in the sense that beside the technology that has been achieved, there is also a need for new delivery of care model. For diabetes especially, there is a constraints and barriers regarding the manufacturing. It is only produced by 3 main multinational companies, which is no other biosimilars are getting into the market to a large extent. Also, the challenges are in the selection, pricing, and reimbursement, in particular in low-income countries because of lack of policy and lack of procurement and supplies. The health system is important in prescribing, dispensing, and even patient education. That's important for the insulin use as well. So this all has to be addressed when we are talking about insulin availability. In a global survey carried out by IDF for the supplies of medicine, and it is found that 1 in 2 people with type 2 diabetes do not have access to insulin. Insulin is available in high-income countries in 80% compared with less than 15% in low-income countries. So it is concluded from that securing universal access to insulin for all remain a global challenge. How to secure insulin? As these global challenges, we need to address sustainable development goals and follow the pathway of that. Sustainable development goal is the roadmap for the global challenges. These are health, climate, poverty, justice, and equality. For these, health is SDG 3, and in which all other sectors are interconnected. Universal health coverage, which is UHC, is the principle of the health sector. It is important to follow it so that all countries have convened as United Nations members and agreed and committed by the year 2030 to have health for all and by all. By all, that means partnership. And for this, if we follow that, we can secure insulin by the programs of health for all. Where are we in our MENA region? The magnitude of the disease, we have more than 55 million, which could be doubled by the year 2040, and more than $25 million are spent. This is not much in comparing when we could take with other regions. There are more than 500,000 deaths per year, and gestational diabetes is 1 in 9 live births affected by hyperglycemia in pregnancy. Not only that, but we have 2 countries, that is Pakistan and Egypt. They are mounted in the 10 largest countries who have the highest number of people of diabetes in the world.
So by the year 2045, Pakistan will be number 3 and Egypt will be number 7. Pakistan will be bypassing United States and Germany will disappear from the list. There is no data to have the people of diabetes who are short of insulin. So from this, I made an attempt to make an estimation by gathering the countries of low-income countries. The region is divided into 3 categories of income: high income, low income, and middle income. Low income, we have 3 countries, middle income 12, and high income 7. Out of these, the low income and the middle income of the instability areas, total is about 9.2 million. So from this, added to it, the people with diabetes in the middle and upper high income is 45. So that means if we calculate this and assuming that the number of people with diabetes who are taking insulin is 30%, and also the number of people with diabetes in low income are probably 80%, and number of people of high income and middle income, the shortage of insulin is 20%. From this, the calculation, the total people with diabetes in MENA region short of insulin is 5.5, and people with diabetes who are using insulin, total of that is 16%, 16 million. From this, we can find out that 1/3 of the people with diabetes are having shortage of insulin, those who are using insulin. You can see this is a very big figure, more than 1/3 are having short of insulin. That means we need to act. When? It has to be immediate. And if we want to follow that, it has to be build 3 important actions. That is, build partnership and multi-sectorial action. The government should have good procurement practice and differential prices, and then reduce tax and duties. I discussed briefly with some leaders of the members association in the region who are probably have high shortage of insulin. Of these, from Lebanon, Palestine, Yemen, and Afghanistan. From Lebanon, Dr. Muhammad Sandid. From Palestine, Dr. Abu Halawa and Dr. Barishir. And Afghanistan, Dr. Kabir, and Dr. Yemen, from Yemen, Dr. Atif Said. They all stated that they are having severe shortage of insulin due to the current situation. And in Lebanon, due to the economic crisis, the price of insulin are escalating very high, and even it is not found, it is available in the black market. So for this, they have created collaboration with the municipality in all Beirut, and also with the help of the diaspora, they have provided insulin in certain pharmacies. In Palestine, they have already been in collaboration with the IDF MENA region, the task force headed by Nizar al-Basha and Muhammad Sandid and Dr. Nadima. They worked for the refugees in these areas, and also they helped a lot during the Gaza Strip crisis. In Afghanistan and Yemen, they have working hardly to make insulin available in the countryside outside the capitals. In Pakistan, also they have worked with partnership. Actually, Dr. Abdul Basit, Professor Abdul Basit, has made a very interesting participation on this webinar of World Diabetes Day about the availability of insulin in Pakistan, and also they're building their partnership. In Sudan, we are following suit and building a partnership and investing on social corporate responsibilities. So this is an example of investment of social corporate responsibilities. An investor from Saudi Arabia on agriculture in northern Sudan has donated this multi-million-dollar diabetes center, in which provide excellent services for people in the northern Sudan, providing also insulin at least for 10 years from the time when it was established.
other partnership we have with World Diabetes Foundation for the last 15 years, and also with the pharmaceutical industries like Novo Nordisk and Sanofi, and others in education. But in insulin, we have only collaboration with Novo Nordisk, and we started with the program Changing Diabetes in Children, CDIC, which is collaboration between other Minister of Health and other our diabetes association. For that, we have the objectives of this is to give free insulin and training healthcare professional, building infrastructure like clinics for diabetes, and also most importantly also patient education. The results of these are we have established 26 diabetes clinics, trained more than 200, reached more than 2,000 children and adolescents of diabetes, and being given all the necessary supplies and medication. Another project which is started recently, it's called iCare, which I stand for myself, and care stand for capacity of healthcare people, and affordability to give insulin with affordable price, which is a differential and affordable as well, to reach most of the vulnerable group, that is access of care and improve in that, and empowerment of people with diabetes. This project is working on 80 states, and Novo and National Medical Supplies Fund are collaborating in this project together with the Sudanese Diabetes Associations. From this, we can conclude that and give very specific suggestions to take action on immediately, and also the members association and IDF MENA should be the watchdog for these actions, and to have an appropriate advocacy for it. These are: number one, government should dedicate sufficient fund to guarantee health for all, which is a universal health coverage, and must include insulin in the health packages. Government and pharma industry must implement concrete responses to address differential prices. Government, WHO, and IDF should work closely to develop national diabetes program. IDF MENA collaborate with stakeholders and the pharma in the development of advocacy program for securing insulin for vulnerable group. We know that the pharma are contributing much in the education, but they should work more in the development as part of their social responsibilities. IDF MENA formulate a functioning committee for insulin availability. We actually have an active group called Insulin Centenary Committee, headed by Dr. Shabin, that has been working actively to come up with suggestions. So here we also suggest out of this to have a committee for insulin availability to be represented by two members from each sub-region. The region is the MENA region is divided into geographically into six regions. So one or two from each, so that we could have wide representation, and most important, to have representation from the low-income country and countries of special situations, so that this is the issue that is more important for this group. From here, I say thank you very much for giving me this opportunity to address this important issue, and thank you.
Thank you, Dr. Elton. It was very interesting and informative lecture about the availability of insulin in the MENA region. First of all, I want to thank my friend, Professor Jamal, for organizing this important meeting. And I would like to say Merry Christmas to our Christian colleagues, because you know that it is a Christian time. And it's very difficult for most of them to participate in the meeting because they want to be with their family. But I want to thank them for joining us for this Congress. The next speak of this session is about new initiatives, and the speaker will be Professor Mona Menef. She's the professor of endocrinology and diabetology. She's a member of the Tunisian Endocrine Society. and she's a founding member of the Endocrinology Society of SFAX and the Research Unit Metabolic Syndrome Obesity. She's the Vice President of Medical Research Development Association, and she's also the General Secretary of Tunisian Association of Gynecology, Childhood and Adolescence, and she's the head of the research group of endocrine disease in Human Molecular Genetic Laboratory. Professor MENA, you have a very, very huge publications, and you have a very long CV. I can't go through it, and the participant can go to the platform and find everything about you. The floor is yours.
Thank you, Mr. Chairman. Thank you, dear colleagues, for adhering to this important Congress. Big thanks to Professor Jamal Belkadir, President of IDF MENA region and the organizing committee for the huge effort and outstanding organization. My talk will focus on advocacy to diabetes in MENA region with a special interest in the recent and upcoming initiatives. I will first survey the epidemiological aspects worldwide and in MENA region. Then I will account for the different impacts of the disease on individual communities and governments. And the final and most important part is devoted to the several actions showing the national and regional advocacy actions around the 21 MENA countries. For epidemiological aspect, as we all know, around the globe, diabetes is a serious health threat across the borders and the social classes. In fact, today, more than 530 million people will suffer from diabetes. And what it is dangerous that the number of patients is exacerbating. In fact, in 20 years, the number of adults patients has tripled, as we can see here, from 151 to 536 million in 2021, and estimations are on the rise. So without sufficient action to break the colossal expansion of this pandemic, we will have more than 780 million people with diabetes by 2045. What about epidemiologic data in MENA region? We are on top of the list, as we can see here, with a second rank after Africa, although the whole world is witnessing a fast increase of the number of patients. The MENA region represents the highest rate of increase. In fact, we account in 2021 for a growth rate of 87%, almost twice the worldwide rate, which is about 46%. As for the prevalence rate, MENA countries are #1 and are expected to keep this position in the future. And as seen in the table, we are about 60% and we will reach 19% in 2045. These figures are in fact frightening, but unfortunately they underestimated. In reality, as undiagnosed cases are also huge, notably in low and middle income countries, as indicated in this classification made by the World Bank. Many of the MENA countries, as we know, fall within this classification. In fact, 37.6% of cases in MENA region are undiagnosed, as we can see here. Consequently, it is positioned at the third rank among the 7 IDF region. To sum up, then, the MENA region is overwhelmed, is ravaged by diabetes, and the prospects are on the rise, and the impact is devastating. As the individual, social, and economic impacts, which is the focus of the third part of my talk. In fact, the proportion of total deaths associated with diabetes and before age of 16 is an indicator, in fact, of the relative burden of diabetes within each IDF region, and the highest proportion of total deaths before 60 years associated with diabetes is scored in MENA with 44.5%. From a socio-economic point of view, as we can see on this curve, on this line curve, worldwide diabetes-related health expenditure is in inexorable growth over time, and the expected amounts will be higher and higher as the bar chart shows it. Similarly, the MENA countries spend more than 15% of the total health expenditures on diabetes, as seen in that chart, and these expenditures in fact are due to the direct and indirect causes of diabetes. In fact, the causes of treating complications account for over 50% of direct health causes of diabetes, and in indirect causes of diabetes add an additional 35% to the annual global health expenditures. To conclude, there is a strong need for effective intervention strategies and policies to stop the increase in the number of people developing diabetes and socio-economic impacts. Now, allow me to move to the most important part of my talk, that is advocacy and actions on diabetes in MENA regions. First of all, I will survey the history of advocacy for the rights of the diabetics at all levels, and as we can see here, the history in fact started in 1999 with the recognition of the World Diabetes Day by IDF and supported by WHO and United Nations. And from this date, the 14th of November of each year has become the most important date for celebrating sensitization for diabetes around the world. Then over the years, the history continues with several milestones in the rank of advocacy strategies, with a number of commitments by governments and experts in order to intensify the protection of people from NCDs and notably from diabetes. There were a cascade of events to advocate for diabetes, but excuse me, but I will rapidly go through a different station to win time. In fact, and finally, through this process, the 3 high-level meetings on NCDs, we had noted the need for national advocacy to ensure attendance of policy makers, and in this context, IDF called to action through its whole network. Here, the media and social networks were utilized to campaign for advocacy with the following list of priorities, as you can see here, by increasing funding for diabetes research and development programs, preventing diabetes, ensuring that insulin is affordable for everyone whose life depends on, providing free access to healthcare coverage, eliminating discrimination against people with diabetes, and promoting health equity. Recently, IDF led an action strategy for requesting the support of national policymakers, promoting through national media, and creating specific national campaigns for each country. Let's see together now some recent actions already done in the different IDF MENA countries. I started the actions taken by our Association of Endocrine Diabetologists of SPACS, headed by the dear Dr. Mohammed Boulassoul, in collaboration with the local civil society. This is the celebration of the World Diabetes Day in 2019 in a low-income interior city of Tunisia, with diabetes tracking and education caravan to the rural area. Another celebration including an educational webinar to the large public in 2020 during the COVID lockdown period. And these are also other aspect of celebration with a combination between sensitization and cultural, sports and artistic events, like the visits with patients of some historical monuments, like we can see here, and the blue light illumination, symbol of the blue circle, which unifies all the diabetes activities under the same sky. Here are shown the dietary workshop and the SFAX Diabetes Marathon in 2019, and advocacy events are organized also in all IDF countries, not only in Tunisia, from Lebanon to Morocco, to Pakistan, United Arab Emirates, Oman, Lebanon, the second association that is a DILAB. This is a photo from DILAB activity, Egypt, Libya also, Qatar, Saudi Arabia, Jordan, Iran, Palestine, Iraq, Afghanistan, Syria, Yemen, Bahrain, Algeria, Kuwait, and finally Sudan. And all of these activists are warmly thanks for their activities. This is not everything. In fact, the work is evolving and advocacy actions also. This progress is depicted in the new concretized initiatives and suggestions for the future. This is done through new communication delivery modalities, notably telehealth webinars, social media, software applications, and virtual education programs. So, this is an example of educational video about insulin therapy realized by dear colleague Dr. Leila Haddad, and a second one about surveying Tunisia culture as regards insulin therapy during the insulin centenary celebration simultaneously with the World Diabetes Day in 2021, and both videos were obviously published on the Facebook page of AEDS, our association. The same occasion was an opportunity to realize a workshop about the benefits of olive oil to the diabetics, and other activities under the height of the blue circle that we found formed with music, like as we can see here, and a lot of fun with young collegians, Tunisian collegians. Every year, IDF choose a new slogan to highlight the theme that we adopt on that year. In 2021 and the following 3 years, the theme is access to diabetes care. If not now, when? Access not only to medicine but also to education, self-monitoring, healthy diet, and physical activity. The AEDS also have organized during the months of September and October 2021 at the Diabetes House of SFAX painting workshops with the profile of type 1 diabetes children. These are some examples of very beautiful painting that express finally the feeling and the experience of the young patients with the disease. Another artistic representative of dietetic therapy for children that was realized by type 1 diabetic children and their mothers to highlight the healthy diet for these patients. Also, media coverage to advocacy for diabetes was solicited at the different events around the IDF MENA countries. Here are 2 examples from first from Tunisia in 2020 under the theme of nurse and diabetes, and from the second one from Lebanon in 2021, organized by our chair elected Dr. Mohammed Sandid with large media coverage. In Jordan, Dr. Najima Shengan, diabetologist and president of Jordan Association Diabetes, said in an exciting, as we can see here, manner to sensitize the general public and the policy makers, leaders, governments, head of states, Several MENA region also associated, developed also some educative software application. Here an example for this application realized by a related organization, DAR Alliance for Diabetes and Ramadan Alliance Group. The IDF MENA region should adopt and develop like this application. The end up, we have to end up, and at the end we have made some suggestions to expand the scope of advocacy for diabetes at the virtual and real worlds. Based on our experience and through participation to the World Day of Obesity, this initiative is intended to establish partnership and identify key advocacy priorities network. In fact, networking is a key to successful advocacy and advocacy in international data organization of webinars with other association or elaboration of educational videos or educational flashes during World Days touching on theme intertwined with diabetes, like the World Health Day, the World Day of Tobacco, like the World Day of Hypertension, and so on. This will be an opportunity to advocate for diabetes. Also, a program to taxing the soda and sweets products, as suggested by our chair, Jamal Kadir, will be helpful for our diabetics. Reduction and limitation of customs and tax of medicine devoted for diabetes and insulin are also beautiful suggestions also. Moreover, for virtual networking and advocacy, IDF MENA should create Twitter, Facebook, LinkedIn, Instagram, and other social media accounts as another IDF region like IDF of Europe. It is so it is worth mentioning that, for example, for Qatar Association of Diabetes, there is a website, also a website of Moroccan League Against Diabetes. And it's important to mention that a website for IDF MENA is under construction and headed by Professor Jamal Kadir, and we hope it will see the light as soon as possible. This is an example for Twitter site for IDF Europe. So to conclude, in the world and more pronounced in the MENA region, the epidemiological condition pleads in favor of worldwide pandemic. The prospects for the future indicate a huge rise of numbers and prevalence of all types of diabetes. The new lifestyles and the rapidly growing urbanization have further sped up the growth rate, but the number of undiagnosed cases remain alarming, especially in low and middle income countries. The result is a huge number of deaths, billions of dollars spent for curing the patients, and a dire impact on sustainable development. Fortunately, IDF is here to adhere to advocacy for diabetics in all parts of the world. And in the MENA region, we celebrate, campaign, lobby, and sensitize in all directions. And in the future, innovation and technology are the stakes of success. We need a further virtual coverage and an intense presence in the social media to raise consciousness of the ever-expanding diabetes. And thank you for your attention.
Thank you very much. And I think if you allow me, Dr. Amira, to introduce Dr. Hazem Abdel-Razak. So the third and the last speaker of this session will be Dr. Hazem, Professor Hazem Abdel-Razak. He's the head of the Iraqi Diabetes Association, and he's a former professor and consultant interest in Al-Muntasiriya College of Medicine and Al Yarmouk Teaching Hospital in Baghdad. Former consultant interest in the private clinic in Muscat, Oman. Currently consultant internist of the Red Crescent Hospital in Baghdad. Professor Hazim is going to talk about the need for national programs. Dr. Hazim, the floor is yours now.
Thank you very much for the introduction. Why diabetes matter, or why there should be a diabetes program? Because diabetes matters much. And why diabetes matter? Simply because that diabetes is at a crisis level and it is escalating. The annual mortality from diabetes is more than 4 million deaths globally due to direct effect from the disease itself. And also the figures, as you see here, are escalating. At the year 2019, there was around 463 million cases. At this year, it's almost 537, and it's expected to be more than 700 million persons with diabetes. And here in this region, in the Middle East and North Africa, where we live, the figures are also very worrying. There is almost an increment of about 95% between these 2 years, from 2019 to 2045. Also, 4 out of 10 countries with the highest prevalence of diabetes all over the world exist in this region. Diabetes also matters because it's a major contributor to cardiovascular disease like hypertension, ischemic heart disease, stroke, and many others. As well, the undiagnosed or poorly controlled diabetes, it can lead to a devastating complication. Also, diabetes can also exacerbate some major infectious diseases like tuberculosis, HIV, and many others. Why diabetes matters also? Because the cost of diabetes, of management of diabetes, is unsustainable, especially for the middle and low income countries. There will be also loss of labor productivity and decreased rate of economic growth from enormous losses of the national income from a largely preventable deaths from diabetes. Diabetes also has an important impact on poverty, because in countries without social protection and insurance program, the family of a diabetic patient may be pushed into poverty after the diagnosis of the disease. Also, diabetes can undermine human development. The other important thing is that in the recent year, diabetes start to strike a decade earlier. That's why in many countries now the guidelines of when to screen for diabetes is they are starting less than before. Before they were starting at the age of 40 or 45. Now in many countries they are starting at the age of 30 or 35. And recently in the United States, according to the announcement by the American Diabetes Association, they will start the screening program for diabetes at the age of 35. What is good is that most of the national and business leaders are now increasingly aware of the magnitude and consequences of this diabetes epidemic. Also, they are aware that investing in diabetes prevention and care will bring a substantial return. Now we have evidences that intervening is effective and is cost effective, and also we know what to do to prevent diabetes and how to manage the disease perfectly. A larger proportion of type 2 diabetes can now be prevented or delayed, and through a comprehensive package of treatment and support, diabetes-related complications can largely be prevented or delayed. Also, preventing diabetes also would help prevent other non-communicable diseases like ischemic heart disease, stroke, and others, and some serious infection like malaria, HIV, and tuberculosis. Diabetes, in a way or another, is considered to be a developmental issue. Also, it may be related to environment. Diabetes doesn't change climate. Also, climate change doesn't cause diabetes. But some of the vectors that are changing the environment are linked to diabetes risk, such as physical inactivity and overnutrition. So the challenge is great, but so is the reward. Now, the objective is to prevent the development of diabetes through lifestyle intervention by implementing a health in all policies approach, reducing fat, sugar, and salt in processed food, and also policies and programs to reduce sedentary behavior. Also, improving health outcomes of people with diabetes through early diagnosis and cost-effective treatment. And here, 4 core elements of successful diabetes management have been considered. The provision of essential medicines, supplies, and technologies to establish a regular clinical assessment to detect complications and offer self-management education to all patients or carers, and finding and diagnose cases of type 2 diabetes. Now, in history, the national diabetes programs had started since 1986. These can be simple or detailed, and they can be developed and implemented as a standalone strategy or embedded as a discrete component of a broader non-communicable disease program. In my country, Iraq, our diabetes program is part of a broader non-communicable disease program. These plans must be documented, transparent, and freely available to stakeholder groups. And the responsibility for the diabetes program must be located at the highest level of the government, preferably at the Prime Minister office. A national diabetes program is a systematic and coordinated approach to improve the organization, accessibility, and quality of diabetes prevention and care, and is usually manifest as a comprehensive policy, advocacy, and action plan covering the main types of diabetes, type 1, 2, and gestational diabetes. Also, it should cover the whole continuum of care from primary prevention to treatment and palliative care, and also cover the resources, services, and systems that support prevention and care. The core elements of a comprehensive national diabetes program are primary prevention to prevent the development of the risk factor, secondary prevention to prevent the development of the disease, and tertiary prevention to prevent development of complication through early diagnosis and effective monitoring, treatment, and care of people with diabetes. The core principle underpinning the National Diabetes Program is social justice, and in practice, this means an access to basic requirements for effective and affordable treatments, diagnostics, and technologies for all who need them, and also consideration and affirmative action to ensure that access is afforded to vulnerable groups such as the young children, elderly, indigenous minority, and the poor people. Who should be involved in the planning and implementation of the diabetes program? In addition to the usual professional and consumer diabetes group, pharmaceutical companies, and WHO, these might include government departments and agencies such as agriculture, treasury, transport, planning and education, food industry organizations, employers associations and employee unions, health insurers, private sector, philanthropic organizations, and non-diabetes, non-governmental organizations should all be considered and engaged where possible. So in summary, every country should have its own national diabetes program, and the program should be tailored according to the local needs and available resources. The program has to be updated periodically to follow the new updates in prevention and management of the disease. And everybody should understand that, especially the politicians, that investing in diabetes prevention and care would bring a substantial return. And the responsibility for the program must be located at the highest level of the government. And finally, I would like to say that a diabetes program is not an option, but an urgent requirement. Thank you very much.
Thank you so much, Dr. Hazim. It was very informative lecture. And I can ask Dr. Abdullah. I could see that there were some questions. First question was about, I'm not sure that it is relevant to you, Dr. Mohamed Elton, or not, but they asked about stem cell. Is there substitution for insulin therapy or not? But if you want to refer to this question.
Well, I could put it in another way, that we are far behind. He may be the one who is asking the question, is probably asking whether we can bring an endogenous insulin replacing the pancreas. So this is probably in the future. The stem cell is still going in process. There is a legal issue, there is a cultural issue, there is industrial and pharmaceutical issue to bring this more to the community. So it is probably going on, but it is beyond our lifetime. So we still have to stick to insulin as an exogenous element.
You are very young. Maybe it's beyond my lifetime, but it's not yours. Thank you so much.
Probably will be the...
It was a brief answer.
May I comment, Dr. Amir? This is too early. This is too early for the region to start stem cell therapy. In fact, one reason is that the cost is very, very high. The second thing is that the success rate is not that good. I think it is no more than 50 to 60%. Thank you.
Okay, thank you so much. And I have a question from my side about the availability of analog insulin, the modern insulin. Do you have any data about this in our region? Is it available in all the countries in our region or not?
The analogs. Yes, I think there is the analogs is available in high income countries, because now it is a differential process of the human insulin is going less down. So if you take the high risk countries, the availability will be up to 80%. That could be in the high income countries, but in low income countries it is extremely low, as it is for the same proportion that I gave. Also, it is because this is always depends on the prescribers, and also the companies are pushing more towards the human, towards the analog insulin. So part of the to make availability and the accessing rate more higher. So the government should differentiate and make differential prices and make human insulin more available to the vulnerable groups. So that is one of the recommendations that we should stick to. I mean, we should not let the human insulin to die out, because that is cheap and that is affordable.
Mm-hmm.
Can I comment, Mohammed? Can I comment? صباح كامل. Can I comment, Amir?
Yes. Do you want to go to our session? Yes, of course. Why not?
No. I just to comment about this. The conventional insulin can still be used with education of the patient because of the cost. You know, I just revised an article from the Endocrine Society 2020. Talking about the back to NPH insulin, but with using the technology of monitoring and education, you can reach the target, you can reach the goal, because now the price of analogs going up. And in our area, we must not think much of this option generally, but this is an individualized. And even in the high-income countries, the insurance companies now cut short some of the high-value therapies and looking for the cost. So we can use the conventional insulin, but with proper education for both the patient and the healthcare providers, how to use and how to manage.
Thank you so much for your comments.
Yes, yeah, Dr. Amir, just a comment regarding the stem cells treatment for type 1. I think here in Qatar, there is a promising results come from the Biomedical Research Institute in the Hamad bin Khalifa University. They are collaborating with Professor Milton in Harvard. I think last time when I met this researcher in that institute, they told me that within 3 to 4 years, they will be available here in Qatar, inshallah.
Very good news, very good news. You are the first always in the region.
In the MENA region.
Yes. And maybe in the world, why in the MENA region. And the second question was just about the reimbursement of insulin and how we can, they asked how we can convince the government to be the reimbursement for insulin. Do you have any data about reimbursement of insulin in our countries in the region?
Yes. I think, as I mentioned in my presentation, the best way is to follow the Sustainable Development Goals, in which the SDG 3, which is a universal health coverage, it is a duty of each government, and it is a human right to give basic life-saving drugs free to, and it should be equitable to all people. And insulin should be one of them. So, and we are the advocate. I mean, our MENA region, our members association should be advocate to help the vulnerable groups for that. So this is the flag that we should carry on, because otherwise it will not be really a reality, whatever. I mean, that is what we are working on now, is a fragmented effort. But push the government to give these essential drugs according to universal health coverage, and it is health for all and by all. By all means that all segments should act and help to make health for all.
Sorry, Amir, can I thank you so much for the lecture, important about insulin success. I suggest that we copy the Pakistani experience, establishing an insulin bank in the region to face in the successive crisis in the region, difficulty obtaining insulin. It's very difficult in this moment.
Mm-hmm. Completely true, completely true.
Thank you.
I mean, other possibility is that to the social corporate responsibility of these farmers. The farmers are gaining billions of dollars. So they are having social corporate responsibility, and they should help the vulnerable groups by making insulin available, and particularly the human insulin. And some models are working on like CDIC. Now in Sudan, CDIC, all children in Sudan are having free insulin as part of this social corporate responsibility.
Very good, very good.
Thank you. Dear Abdullah, Amir, Eltom, Abdul Razak, Sandid, Masbah, and all colleagues. Hello, everyone. Dear friends and colleagues in MENA region and over the world. At the closure of the second IDF MENA Virtual Congress, and as IDF MENA Regional Chair, I would like to express my warm thanks to all speakers and moderators for the quality of their talks, to all participants from different countries who were more than 2,000 participants for 2 days from 75 countries, also for all persons who has participated to the success of the meeting. My deep thanks go to Professor Bolton, IDF President, and Professor Akhtar, IDF President-elect, who has honored us to the scientific committee for all the effort in the choice of the topics and the quality of the speakers. My warm thanks for all members of member event and for the professionalism and the quality of their work. Also, pharmaceutical company, Merck, Lilly, Sanofi, and Novo Nordisk for their support. I hope that the second virtual IDF MENA Virtual Congress was up to your expectation, and I want to announce that all lectures presented during the meeting will be available online shortly. All attendees will receive the certificate of participation. At the end, I want to mention that the coincidence of the date of the Congress with the Christmas holidays is beyond our control. We apologize to all Christian friends, and we promise you that it will not be repeated. Wish you Merry Christmas and Happy New Year for all, with health, happiness, and success. Thank you again, and see you soon next year during Scientific MENA Blue Circle webinar, and hope to meet you face to face shortly. Thank you.